Body procedure are, it can be done under GA or brachial block, patient position supine, incision direct posterior approach for the ulna, and for radius anterior handy approach. The procedure is extraperiosteal excision of distal ulna with ulnar corticotomy, fixed by uniaxial external fixator and guided growth by reference KR. The postoperative management is lengthening state from 5 to 7 days after operation. Per day length increase 1 millimeter. I remove stitches in 14 days. XP is removed after gaining proper length and consolidation. Here are my case. Case 1. It shows it is Masada type 1, shows exclusive in the distal ulna. We have corrected the radial deformity and fixed by a small DCP along with ulnar corticotomy and fixed by uniaxial external fixator and guided growth by reference KR. This is the postoperative X-ray and these are the follow-up X-ray. This is the final follow-up X-ray before operation and after operation, the proper gaining of the ulnar length along with correction of deformity on the radius. This is the clinical photo and this is the video of the patient. This is my second case. This is also Masada type 1, in where exosis is present in distal ulna only. We have done same procedure in this patient. This is the postoperative X-ray, and these are the follow-up X-ray, and these are the final before operation and after operation, and this is the final follow-up X-ray video. It's my third case. This is Masada type 2B, in where there is a subluxation of radial head. We have done only excision of the distal ulnar exostosis along with this is the follow-up X-ray and this is the final X-ray, postoperative final X-ray. This is the clinical video. Complication: one patient developed superficial infection that is managed conservatively, and another complication is extreme pronation and sometimes supination are restricted. The take home message is ulnar lengthening with use of uniaxial external fixator is a safe, effective and less expensive method. It improves the functional quality of the hand, make cosmetically acceptable form and hand, and can relocate the radial head and normalize the distal radioulnar joint. Thank you for patient hearing.
Thank you, Biplab, for your nice presentation. Now, question from audience to Biplab. One questioner can only one question can ask, and only two questions.
Thank you, Biplab, for nice presentation. My question is, I think the Elizarov is a good method for lengthening of the any bone. Why use uniaxial XPs for lengthening?
Thank you, sir, for your nice question. Thank you, sir, for your nice question. Maximum literature shows that they increase the ulna by using Elizarov external fixator, but in our country's strategy, or they think that but we think that Elizarov is a sometimes cumbersome, and patient doesn't agree to take Elizarov for this type of deformity. For this, why we choose a uniaxial external fixator. Thank you, sir, for your nice question. In maximum case, after lengthening of the ulna, the radial head become relocate. After proper lengthening of the ulna, radial head become relocated to original position, sir. Sometimes we failed, then we convince the patient that in this case we exercise the radial head for good function of the hand.
Time is over. No question. No more question. Time is over. Thank you, Biplab,
Thank you, sir.
for your nice presentation. Our next topic, cervical spine injury. Is late surgery always a failure? He will talk on a talk. Dr. M.D. Ziaul Hassan. Dr. M.D. Ziaul Hassan.
Dislocation. She was neurologically she was Asia B. Came to us with the day 1 of injury and with no associated injury. So what we had started, we started the conservative treatment and we put a strong traction also. But gradually she was developing some respiratory distresses and later on she enters into respiratory failure. So we had to transfer her to intensive care unit. But it was very sad that after fighting 2 days in ICU, we ultimately lost the patient. My another case I want to show, that 37 years male with a 70 days old cervical fracture dislocation. Neurologically he was Asia C. Came to us with this kind of X-ray and MRI. And his neurological level was so deteriorated that he barely could move his hands and not even moving his lower limb. So we were in a bit of a doubt. What should we do? That it is a very late case, more than 2 months old and neurologically deteriorated. So should we go for surgery or should we leave him alone? So that was a very big question playing in our mind. And what expected outcome can we deliver to the patients by doing surgery? That was also a question. And or if we do the surgery, even it can failure. So today my talk is cervical spine injury, is late surgery always a failure? If we see the epidemiology, the incidence of spinal cord injury worldwide, annually it is about 10 to 83 cases per million. And among these injuries, 1/3 are cervical spinal cord injury. So the impact is very profound and most of the patients need systemic treatment and mostly they need surgery, surgical relocation and fixation. So there are debates. If we think about surgery, should we go for early surgery? Should we go for late surgery? Some says that the early surgery has a good neurological outcome. Some says sometimes early surgery can deteriorate the neurological outcome also. So let's see what literature says. This systematic review done by La Rosa et al., they advocated that less than 24 hours have a better outcome than the later surgery. And two very important study on cervical spine, that is spinal trauma study group and STAS case study, they advocated a 24 hours cutoff value to define early surgery and late surgery. Now let's come to the point, what occurs after a cervical spinal cord injury? Initially there is a primary event, that means the cord compression, fracture, shearing force, that is followed by the secondary cellular events. Those are the inflammation, cellular changes, apoptosis. So what surgical intervention aims at? The surgical intervention aims at reducing this secondary damage for a better functional outcome. So if we look at this study by a famous researcher on cervical spine, Alexander Vaccaro, he had done a very big series on 1548 patients. And he showed that the early surgery, that means less than 24 hours group, has a better improvement of the ACI impairment score outcome, at least 1 grade improvement. He showed that the early group has a better outcome. And another study done by Michael Fellings on 313 patients. He studied on the up to 2 grade ACI impairment score improvement in surgical groups, and he showed that the early surgical group has 19.8% improvement. And the late group has 8.8% improvement, and complication wise, early group has a better outcome, less complication. And he showed in his study that from even Asia A, at least 1 grade improvement occurs in 43% of the early cases and 37% in late cases. But there was controversy. Another scientist, Van Middendorp, he questioned the result of the failing study, and he thought that the sample size was not large enough and the analytical techniques were not incorrect. And in his study, he advocated that there was no significant difference neurologically in early surgery or late surgery. And this is the latest recommendation from AOSPINE and AOSPINE North America, as well as the Congress of the Neurological Surgeons of United States. They advocated early surgery in case of cervical spine and all case of spinal cord injury, but the quality of evidence was low and the extent of the recommendation was weak. Now please come to our scenario. What is happening here? We know Bangladesh is a very large country with densely populated area, and Dhaka is the only one mega city with all the surgical facilities. So reaching patients from here and there to the center of the Dhaka, it takes time. So what we had to do, we had to operate late most of our cases. So this is my study. It was a prospective interventional study done in Nitor, and the study period was July 2021 to July 2023. The sample size was 15. The surgery done anterior surgery, and all cases operated late. Outcome analysis was done by Asia scoring, VAS scoring. Breed oil fusion grading was checked to see the fusion status, and our study population was only those patients were taken who comes late after 24 hours and operated and completed at least 6 months follow-up. So I had some inclusion and exclusion criteria. So if we see the surgical techniques, we position the patient accordingly. I mean, neck extended position, we put the left-sided anterior neck skin incision, and after proper dissection, we reach the dislocated level and confirmed it by CM. And then we done the relocation maneuver, and then we prepare the disc space, and then take a tricortical bone graft from iliac crest. After harvesting the tricortical bone graft, we put the bone graft in the disc space, and we then ultimately put the antecervical plate and screws for stabilization. So if we see the result, most of our my age range of my patients was 22 to 55 years. So the active group, age group was mostly involved in this kind of injury, and mostly patients were male, and most common injury was fall from height. Most common level was cervical 5-6, and if we see the timing of our surgery, one case we operated within 7 days, but it was after 24 hours. 7 cases, that is the most number, we operated in 7 to 14 cases, 14 days. And if we see the neurological outcome, at least 1 grade neurological improvement was achieved in 10 patients, 2 grade neurological improvement in Frankel grading achieved in 3 patients. So 86% of the patients has a very neurological improvement, and only 1 patient of Asia B remained at Asia B. All other patients improved at least 1 AIS grade. And the VAS score was postoperatively significantly reduced. And if we see the McNabb criteria, 72% of our patients have an excellent and good outcome according to McNabb criteria. If we see the fusion, 80% of the patients, we achieved a Breed-Oil fusion grade 1 fusion. And if we see the complication, 2 patients had postoperative dysphagia, 1 patient has neck pain, no neurological deterioration was there. And now come to the first case we have shown. That was a very old case, and what we have done, we have done antecervical discectomy and fusion. And you can see the postoperative X-ray, 6 months postoperative X-ray, there was excellent fusion in the fusion level. That was Breed-Oil fusion grade 1. And this is the beauty of the surgery. If you see the 6 months postoperative follow-up of that patient who could barely move his hand, now he's taking care of himself, and he's eating himself, and that's all. So this is the beauty of surgery, even we do it late. So I want to conclude like this: early or late, clinical judgment plays a very important role in decision making. Assuring the patient's hemodynamic stability is a must. Incomplete injury always have a chance to recover, even irrespective of the timing of the surgery. And we should have a national guideline for managing a spinal injury, which could help in decision making to give better support to our patients. Thank you all. Thanks for patience hearing.
Thank you, Dr. Jiaul, for your nice presentation and timely finished. Dear audience and learned audience, again you ask 2 questions only to Jiaul Hassan.
Dr. Jia, thank you
Sir.
for your presentation.
Thank you, sir.
In an older case, your series is an older case.
Sir.
Say it is more than 4 weeks or 3 weeks, perhaps many of your cases. In that situation, do you think that every cases can be able to be reduced from the anterior side in a fracture dislocation cervical spine C5-6?
Sir, thank you, sir. Thank you for your nice question. Sir, basically, not all of our cases are very old. What we have done, we done late surgery according to international guideline. They say that the early surgery means less than 24 hours duration, and late surgery means more than 24 hours duration. So what we had to do, we operated every patient after 24 hours, but not all the patients was operated like 2 months, 3 months. But yes, 3 cases we have operated. It was more than 1 month old. And sir, your point is very valid that the anteriorly correction of dislocation sometimes very difficult in case of the old cases. But we what we have done, we prepared the disc space by denuding the disc space, and we cleared the ancovertebral joint completely on both sides. And when we put a Casper distractor, we got the advantage of distraction as well, and we achieved the reduction that is that way, sir. So.
Thank you for nice presentation.
Sir.
Without neuromonitoring, how will you assess the degree of stretching of the spinal cord? Is
Sir,
it a risk or not?
Sir, thank you very much. That is a very good question for me, sir. Yes, sir. Yes, sir. So this is a very big problem we have. We don't have neuromonitor always, and the problem is what we in my series we did, sir, that we observed the above disc space and the below disc space, and when we put the Casper, we never distracted it that much that the upper space and lower space. I match the ratio with the upper and lower space. So excessive distraction of the cord can deteriorate the patient post-operatively. But we don't have neuromonitor. That is our lacking, sir. But somehow we got lucky, sir. Without neuromonitoring, we should not do this kind of series. Yes.
So no more question. Thank you, Ziaul Hassan again. Our next presenter, Dr. Taposh Mondol. He will talk on transcalcaneal rationale, a unique way of management of CPT. Dr. Taposh Mondol.
Good morning, sir. Pseudoarthritis of tibia, a unique way of management. I am Dr. Taposh Mondol, Assistant Registrar, NITOR. CPT refers to non-union of tibial fracture that develops spontaneously or after trivial trauma in a dysplastic bone. CPT is rare and usually develops in first 2 years of life. Etiology is not clear, but incidence is 1:250,000. A strong association with neurofibromatosis type 1. Natural history, failure at maintaining union, even when union is initially achieved, leads to repeated surgeries and secondary changes. These include valgus ankle, leg length discrepancy, knee malalignment, and hip dysplasia. Pathology. CPT is not bony, but it's periosteal. Thickening with hamartomatous transformation of the periosteum, strangulation of the bone with atrophic changes followed by vascular changes, failure of remodeling leading to stress fracture, Pele et al. There are many classifications, but Boyd classification is also more popular. There are 6 types described in 1982. This is type 1, interboing with tibial defect. Type 2, most common, but worst prognosis, that is hourglass constriction, spontaneous fracture, and tibia become tapered, rounded, sclerotic, and obliterated. Type 3, congenital cyst. Type 4, sclerotic segment with a stress fracture, and type 5, dysplastic fibula. And type 6, intraosseous neurofibroma and schwannoma is evident. Primary methods of treatment of CPT: internal fixation with IM rod, external fixation with Eligerov, either internal and external combination, and vascularized fibular transfer. Historically, resection of the hamartomatous fibrous tissue is the part of many treatment protocol, but it does not ensure healing or prevent refracture. Treatment depends on the age and type of the pseudoarthrosis. Primary goal of the treatment: to obtain union, correct the diaphyseal deformity, correct any proximal fibular migration, and prevent refracture. A strategy to achieve union: bone grafting with internal fixation, either plating, intermedullary device, or Eligerov. Microvascular graft transfer, that is vascularized fibula. Excision of the pseudoarthrosis should be an integral part of this procedure, use of bone morphogenic protein and bisphosphonate and long time cast or bracing. Strategy for minimizing valgus ankle. Ensure union of the fibular pseudarthrosis, retaining an intermedullary rod that cross the ankle to minimize valgus ankle. That is important. Strategy to prevent refracture. Splint the limb and orthosis until skeletal maturity and retain an intermedullary nail until skeletal maturity. So we have to, if you want to prevent refracture, we have to give orthosis and intermedullary nail until maturity. Benefit of cross union. Much higher success rate, approximately 100%, by creating a cross union between the tibia and the fibula. The cross union with intermedullary reinforcements of bone makes refracture unlikely. Factor reported to negatively affected union: neurofibromatosis, age of the patient less than 3 years, and previously failed surgery, and years of follow-up treatment. Surgical procedure: excision of the disease part that we have done, transcalcaneal rush nail, quadric and cortical bone graft from the contralateral tibia, that is cortical and cancellous, and tibiofibular fusion by this quadricancellous bone graft. Materials and method. This is a prospective observational study of the 15 cases done in the last 2 years in Newton in the Department of the Pediatric Orthopedics, ranging from 2 to 11 years, and out of which 9 is boys and 6 is girls. Result: 3 cases achieve complete union, 2 cases develop non-union, others are uniting. No refracture, but 1 developed donor site fracture. 1 patient develops only infection, and most of the patient develops variable degree of shortening. Case 1, preoperative X-ray, 2 years old boys, 45 days postoperative X-ray and 7-month postoperative X-ray. This is the source of union. 1 year postoperative X-ray, 1 year the patient can walking independently with some limping, and this patient underwent exchange nailing last month in our hospital, and the last picture shows the exchange nailing, as because the nail become day by day shortening as the child become growing. Case 2, and 2.5 years old boy, preoperative X-ray, postoperative 4 months X-ray and 6 month X-ray show the sign of union. After 9 month X-ray also show the sign of union after 1 year, and the patient after 1 year also admitted in this hospital and waiting for the exchange nailing. The picture is same. This need repeated change of the rush nail because of the patient become growing, and the nail become goes to the fracture site. And another patient is 3 years, 2 years old child, preoperative stage, 6 month postoperative, and after 8 months patient also can walk independently. Complication, shortening of the limb is the most common complication of the diaphyseal, and delayed union is another complication by the rush nail, and distal migration of the rush nail also common, and non-union. Our 3 cases become non-union, need reoperation. Take home message: this technique is safe, less time consuming, and cost effective, and easy to perform. It will help to achieve primary union and prevent refracture, which is burning issue for the disease, and give the patient functionally acceptable limb. Thank you, sir. Thank you for patient hearing.
Thank you, Biplov, for timely
Taposh, sir.
finished time, before time. So now question from audience. Only 2 questions. 1 questioner can ask 1 question.
Thank you, Taposh, for your nice presentation.
Sir. Sir, I think it's better to distal shaft fracture, as because there is exchange nailing is time is delay. Our second case was fracture in the mid shaft. We used the rush nail, and after 1 year, the patient need change of the nail.
First, thank you for.
Thank you, sir.
My question is, you have put a rust nail through calcaneum and up to maturity.
Sir.
Did the nail has caused any problem to the vascularity of the sole, or any infection, pinch infection, or anything else? How did you manage the infection or any complications?
Sir, just one patient shows the just superficial infection in the sole, and we do casting for 2 weeks and antibiotic, and need no debridement. It was healed, sir.
So, question, time of question is finished. So,
thank you, sir.
One thing is very much encouraging. All presenter complete their lecture within time. So now the time of introduction.
Thank you all. Our judges will sit, and after 1 to 2 years we shall declare who win the prizes from this prestigious session, best ever session. Yesterday three presenter of plenary session missed due to time shortening, and first of all we arrange those 3 persons for first presentation. Thank you, sir. Ji, sir.
Yes, sir. We have another prestigious session today. The new thing is BOSCON 2024 Spine Symposium. This Spine Symposium will chair by Dr. M.D. Fazlul Haq sir and Professor Dr. Syed Shahidul Islam sir, and Professor Dr. Ram Chada from India. So I am requesting all the participants, please sit on your seat. Dear participant, please don't move from the hall. Be seated. Be seated. So, কে প্রেজেন্ট করবে? কামরুল হাসান স্যার। কামরুল স্যার আসছে তো? কামরুল স্যার আসছে। স্যার আপনি
This session is very interesting session. It is a symposium, basically spine symposium. The cervical myelopathy is the most difficult area of the treatment.
all the
The first presenter is Professor Kamrul Hassan. We would like to request all the presenter, please be finished within the times. Then we can have 1 or 2 questions. We can, if anybody having any comment, we can discuss together. Actually, all the presenters are very eminent spine surgeon from home and abroad. And the cervical myelopathy is a very burning issue this time, because this surgery is very, the complication is very high. So, topic very interesting. Body of our spine surgeons.
না দিলে ওই যেটা দিছে সেটা তো করবা। কোনটা আলাদা করে রাখো। স্যার এখন ওই যে প্ল্যানারি ইয়ে করবে নাকি স্যার? আপনার এটা না স্যার?
ঠিক আছে, এটা আলাদা করে রাখো।
স্যার এই স্পাইন সিম্পোজিয়ামের মধ্যে আছে স্যার।
ওই কোথায় আছে?
স্যার ওনার ইয়েটা দেন, এখানে দিয়ে দিক স্যার। কোনটা? ওইটার কোনটা আমাকে দিচ্ছেন? এটা এটা
এগুলো সব হাতে পেয়ে প্রিন্টারে আছে, ও কুছে কই
সে পেয়ে নাই তো, সে পেরে কই লাভ আছে? Which one, sir?
Bangladesh.
This one, sir?
You can put all three, no? Okay. One after the other.
Excuse me, sir. I want to draw your attention. Already our President of Bangladesh Orthopedic Society told you that we have missed very important plenary lectures last day due to unavoidable circumstances. So we are starting that plenary session first, and that will be followed by a spine symposium. And this only 3 plenary speaker, and all of them from abroad, and they are VIP plenary speakers to us. And there is a very good relation between India and Bangladesh, and they are the Dr. Ram Chadda from India, and he is here, and he is the current president of Indian Orthopedic Association. Give big clap for him. And another presenter is Dr. Anup Agarwal. He is also the president-elect of Indian Orthopedic Association. And another presenter is Dr. Aravind Kulkarni. He has to leave fast, so we want to give him first for presentation. Sorry for inconvenience. We apologize for last day that we missed you. So you can start, Aravind Kulkarni. Our topics taki.
Thank you very much, dear chairpersons and my dear colleagues. I thank BOS as well as the Bangladesh Spine Society members for inviting us for this mega conference. So, do we need a surgical checklist? Are we so dumb? We study for almost 14 to 15 years to establish ourselves as spine surgeons. This is almost a killer's walkout time from a jail for a murder. So we are the cream of the society. We are the Rolls Royces of the society. We are the Supermen of the society. We are in charge of the spine of our nations. So we are made for bigger things in life. But that is the very reason why we forget smaller issues. Fundamentals get lost. Fundamental gets neglected, disregarded. They get taken for granted. For example, you've forgotten to cross-match your patient's blood for surgery. In such a situation, it's the checklist which becomes your savior. It comes like a knight with a charming armor on a horse. It covers for our ignorance, absent-mindedness, and forgetfulness. We should understand the entire organized world runs on a checklist. The best example is the aviation industry, followed by the construction industry. Forget these industries. Even today's conference works on the template of a checklist, without which we cannot have an organized meeting. So checklist is very, very important. It's played a big role in changing the way we practice in terms of increasing safety and decreasing complications. It is sad to say that our hospitals where we work in is the biggest disaster zone. It's true. And the temple which we worship, where we spend most of our time, is the host for a venue. It's a venue for majority of adverse events. And close to 50% of these complications are preventable. There are 1 million surgical deaths every year as a result of complications. And 50% of these are preventable, and most of them are as a result of silly reasons. Why do such complications occur? Is it failure of expertise? Is it failure of expensive drugs? Or is it failure of expensive devices and machines like robots, navigation, etc.? No, not at all. It is just because of lack of communication, overconfidence, oversight. So it's said by Atul Gawande in this book that to save one life, scores of people must perform 1,000 things correctly and simultaneously like an orchestra. So the patient's health is taken care of in the hospital, right from the watchman who lets the patient in till the nurse who signs him off. So everyone has to work in tandem to make his make his tenure in the hospital safe and successful. So what was the seed for the genesis of this particular spine surgery checklist? It was coincidental. It was the time I had started my practice, and I was facing one complication of the other because of a junior consultant. And at the same time, this book came up of Atul Gawande. And while I was reading through this book, I was facing the same kind of issues. So one patient who had to undergo laminectomy, as soon as I opened the lamina, there was profuse bleeding from all over the place. And I was, being a junior, my resident had just changed. I had forgotten to cross-match blood, and that I lost that patient on table. Similar situations. So we don't have the big inventory in our hospitals. We order implants. So there was a 6.5 mm screw which I had put in S1 pedicle, which got loose, and there was no 7.5 mm rescue pedicle screw which was available. So I had to wait almost for an hour for them to get it, autoclave it, and put it in the patient's back. So these kind of examples. Another example where patient was not informed that if she has any watery discharge after discharge from the hospital, she should come back. She neglected it, she ignored it, she didn't respond to, she didn't get back to us. She came back with full-blown meningitis. She also died. So these kind of issues prompted me to come out with a checklist. So checklists do not teach you how to operate a complex case of scoliosis. Instead, they provide reminders of the most important and critical steps, the ones that even the highly skilled surgeons who routinely do such cases would miss. This is paraphrasing Atul Gawande. So the triumph of WHO checklist is well known. Its efforts in reducing infection rate and mortality rate by 50% is well known. One of the hospitals which was inducted in this WHO checklist manifesto comes from Bangladesh. So why am I reinventing this wheel? We are not reinventing this particular wheel. We are giving a spinal spin to it because the WHO checklist is incomplete when it comes to spine. Spine is humongous. It is pinnacle of permutations and combinations. There is crowding of thoughts when you do a spine surgery. There are different regions, there are different junctions. There is left, there is right. Then there is anterior, then there is posterior. And there are various types of decompression surgeries which require various instruments, and there are various kind of fusion surgeries which require various kind of infrastructure. So there is always crowding of thoughts, and without one basic, one minuscule of these implants or instruments or infrastructure missing, the difference in surgery could be between 1 and 10 hours. It makes a huge difference. Again, checklist of ours has 3 components because it is like preparing for a war. So it is very important to have a pre-operative checklist. All battles are first won in the mind. Forget, wars. Think of, cooking. So you have to cook a delicious meal. You have to have your ingredients in the right proportions before you start cooking. You can't get, you can't think of a masala which you forgotten at the time of cooking. So it's very important to have a pre-operative checklist where you prepare your delicacy, your dish. Then comes the intraoperative checklist. This is basically to identify, to see that things are carried out. Golden hour is followed with regards to antibiotics. You are doing the right side, right level, etc. And then most important part of this checklist is the phase of complications. This is the time you recognize complications and act on. So this is a broad checklist. It's a pre-operative. There is a pre-operative component, intraoperative component, and post-operative component. Going through this would be out of context with regards to time of today. I can share this checklist with any of you if you are interested in. This is a comprehensive 37-point checklist. It was implemented for a year and compared with the previous year where it was not used, and we reduced the complications. Mine being a very, very vigilant list, it came down by about 75%. And following a checklist is not unusual, not a surprise for us spine surgeons. We routinely use this preoperative anesthetic checklist. We rise to the occasion of a neuro monitoring signal loss. That is a checklist that we follow. Why a spine surgery checklist suits our milieu? Because there is a lot of stigma associated with spine surgery. We carry the infamous tag of the failed back syndrome, and the kind of complications that we face are irreversible and unpardonable. And the costs of a complication are spiraling. They are almost more than 1.5 the cost of a primary surgery. High volume of surgery that we face in our countries, in developing countries. We have untrained OT nurses and boys. We have limited and bizarre distribution of resources. For example, a neuromonitoring machine, just 4 or 5 neuromonitoring machines are available in the city of Bombay, which caters to a population of almost 20 million. And our inventory is floating. It is order on demand. And our fellows rotate, residents rotate, so there is no continuity. And we have a very poor and disconnected surgeon and GP algorithm. This checklist had the pride of winning this Safe Spine Surgery Project Award in 2021. It is an international award. It is followed in many countries, this particular checklist now. You know, this was a paper-filled checklist initially. Later on, we were having problem in communicating because the checklist used to be with one particular person. So now I have 4 fellows with me. Everyone can log into this system. I can log into the system. We see to it that the checklist is filled properly. So when we established this web-based checklist, the very next year we got another award by the same Safety in Spine Surgery project for the second time for formulating a web-based spine surgery checklist. It is very well published in various podiums, textbooks, journals, etc. So checklist is the application of knowledge we have consistently, correctly and reliably, is making things happen correctly. Checklist shows that each problem has steps of solving. Each problem shows that, checklist shows that each step is important, shows that the more you repeat it, the more you master it, allows surgeons to concentrate on non-mundane stuff, offers the possibility of verifications, establishes effective teamwork. There is a clear distribution of responsibilities, fosters effective use of resources and skills. It provides patient satisfaction. Customer is the king. It is efficient, reliable, and cost-effective. It's subspecialty specific. It kind of stimulates discussion within the team. So there is a section, for example, for a bailout mechanism. So this stirs discussion among the fellows residents as what they would do in case a particular, what is a plan B if a plan A fails. So these kind of, so if you go through each and every point of checklist, it has an academic point to it. There is a background to it which expands your knowledge and wisdom. So it reduces miscommunication within the team. So you can't point fingers. Again, there's no compulsion to use this particular checklist, but it's made a big difference in our practice. I can classify my practice as one before inducting this checklist and one after inducting this particular checklist and in our practice. And again, you can customize this to your own milieu, to your own environment, to your own hospital. Thank you.
Thank you, dear Aravind Kulkarni, for your timely finish. You can sit here, and before your second talk, I would like to request our guest from India, is the President of Indian Orthopedic Association, Dr. Ram Chadda. He was also the President of Indian Spine Association. So he's a very versatile man with many presentations, many publications all around the world. Let us welcome Dr. Ram Chadda, please.
Have you connected this projector? Or should I take this one out? Okay, I'll do this one. No problem. No, which one? This one? Good morning, everybody. At the outset, may I thank the Bangladesh Orthopedic Society for having invited us from India. It's my pleasure to be here, and I really appreciate the chairpersons, the dignitaries who are all here for allowing me to share my misadventures over the past 3 decades. I have had a checkered history, much alike this gentleman, John F. Kennedy. John F. Kennedy was born on 29th of May 1917 and was assassinated on 22nd of November 1963 mid-afternoon. I was born in India an hour after this gentleman was assassinated in the United States of America. There's nothing to connect the two but for the fact that the 35th President of the United States of America, John F. Kennedy, experienced chronic back pain right from his early 20s. He underwent a total of 4 back operations, including a discectomy, an instrumentation fusion, and 2 relatively minor surgeries. There's also folklore which says that had he had a better back, he could have bent forward and avoided the bullet. Any which way, that is history now. I share with you 10 mistakes that I made in the last 30 years. Most people end with a conclusion slide. I begin with where everybody else starts. I believed when I started spine surgery that I could make unhappy patients very happy. Today I have realized 3 decades down the line that as a spine surgeon, I can only make unhappy patients less unhappy for some time. I repeat, as a spine surgeon, I can make unhappy patients less unhappy for some time. Next, when Arvind and the gang jumped on the MIS bandwagon, I thought it will be a mid-path between non-surgical and surgical options. Today, I firmly believe, and I stand by Arvind, Ayush, who are right there in minimally invasive surgery, that minimally invasive spine surgery is the present and the future of spine surgery. I always thought that we are surgeons, surgery karenge, patient ghar chala jayega. It's only an event and not a process. No, sirs. Spine surgery begins from the moment that the patient comes into your clinic, either walking on a wheelchair or on a stretcher, and ends when he or she smiles and is back home. It's not just an event. Surgery is far, far more important than the product which you use with your hands. It depends on the process that you conceive in your head, and far before that, the purpose with which you do it from your heart. I thought I'm a spine surgeon. I have people with me in my team who will look after non-surgical care. No, sir. It's your responsibility. The onus begins and ends with you. It begins from there and has to percolate. Your team has to shadow you. They have to be your mirrors and your shadows. I always thought I know much about spine surgery. Patient ko kya pata hai? What does the patient know? In an informed, shared decision, in the absence of disabling neurology, 51% share of the decision is of the patient and the caregiver. It's only where disabling neurology creeps in that you come to 50, and maybe over a period of time you have a 51% share. Let them decide. Let them buy the operation. Never sell it to them. I said, spine surgery is an individual event. Yeah? We are world champions. No, we are not. It's a team sport. Together, everyone achieves more. It's an acronym. Right from the secretary who ushered the patient in to the physiotherapist who goes home and looks after the patient finally.
They're all your team. And what's the essence of a good team? The team has to have a low power distance index. What is PDI? You have a pilot and a co-pilot on the aircraft. That's what makes it safe. But what is PDI? PDI is even if the co-pilot is 30 years younger than the pilot, he should not say, Arvind sir, do you think what you're doing may not be right? No, the PDI has to be low. He has to say, Arvind, stop. This is a wrong step. You have to correct your peer because he's no more your mentor or your role model when you're executing, when you're playing, where you're on the aircraft. You have to correct him there before he makes the mistake. I thought today minimally invasive spine surgery, we don't need an ICU backup. No, sirs. That one patient, like Arvind's patient who bled after a laminectomy, can have a paradigm shift in the way that you look at your own self-esteem, the patient looks at you, society looks at you, and the patient spends the rest of their lives, if they live long enough, you may lose them. Have an ICU backup. I said, I don't need a neurosurgeon. I am well-trained, cross-trained. No, sirs. There are certain things that the neurosurgeon is going to do better than you, but there are certain things where you are better. Join hands with them, work as a team, share the spoils, share the responsibility, which is vicarious. You share it, you'll enjoy it. Work as a cricket batsman and a runner. We always work as a team. You have to work together. Wo run out na ho, I have to take the right call. Neuromonitoring. People said neuromonitoring is only adding to the bills. No, sir. It's the only thing available today. I see a lot of Toyota cars here. Even in our country, we have a lot of Toyota cars. But we don't use our seat belts and the airbags till the accident comes in. But we have them in the car. 25 years, 30 years back, we had no seat belts. We had no airbags. That was not level or standard of care. Today, it is a standard of care. Insist on it. Having said that, I share this short journey over the last 3 decades. What have I done? I've looked at my patients, many of whom came back to me and taught me lessons from the mistakes that I had made. I went from that stage of information to knowledge to wisdom. I threw out the irrelevant information and knowledge and am now not just going through life as a spine surgeon, with each day I'm growing through life as a spine surgeon. These are images that I hope and pray none of you see ever. My teacher, Professor Lard, taught me that when life gives you lemons, make lemonade out of it. Turn whatever adversity you have into advantage. So what did we learn? We have orthopedic and neurosurgeons working together. We have fellows who work with us. But despite this, we are the only subspecialty in orthopedics, so maybe in medicine, where we have this tag called failed back surgery syndrome associated with us. We have no failed joint replacement surgery syndrome. We have no failed hand surgery replacement syndrome. Why the hell should we as back surgeons have this tag with us? I have 228 of them whom I revised over the last 3 decades. I had 3 types of patients. 1, there was obviously something wrong with the hardware. 2, there was nothing wrong with the hardware, but there was a step which went amiss during the surgery. And 3, despite everything being right, the patient was still unhappy. We don't know why. All these patients had one thing in common. They were bad enough to come back and say, Doc, do anything, revise the surgery. I can't take it anymore. They were symptomatic enough to consent or ask for a revision surgery. We have had our own share, and we at times have to dare before we care. Having said that, Category 1 are malpositioned implants. What do they look like? Don't tell me how and why this was in there. It was there. He came to me in that stage. Early neurology, 3 years after it was put in. What kept it in there for 3 years, I don't know. I was more scared to take it out than the guy who put it in. This came across the border from India. A man who had unrelenting leg pain for almost 4 to 5 years. And many years later, despite all the blacks and all the blocks and every sort of things being put into his abdomen so that he has no pain, all he needed was just repositioning of the implant. You either remove them or reposition them. There are times where our own patients, this is the first indigenous Indian spacer that I had put in. almost 2.5 decades back, and it just turned around by 90 degrees and said hello to the neural elements. I had to go in at the end of 6 weeks, get it out. I put my instrument in and found out that bone graft had actually started healing. I didn't have the courage to put another spacer, so I put more bone graft and came out. Category 2, where there are patients who had incidental issues during the surgery, or we've excised the pars, or we've had sepsis post-op, or a discitis. Let's say sepsis, a back and front surgery done. Came back at 3.5 months with pouring pus from the rear. The front was fine. All we had to do was remove the pus. The neural compression got reduced. Patient improved, and good enough for us to maintain the anterior part. That means the posterior and anterior being separate incisions, sepsis had not really percolated all the way through. This patient taught me the most, and is going to teach you the most. L4-5 degenerative listhesis, young surgeon wanting to put in the implant and reduce it. I said, listen, I'll fuse one level and I'll keep the other one physiologically mobile. So I used a transition rod where I went up and kept one level mobile and the next one fused. Patient did well, started at the age of 70, came back to me at the age of 78 with an adjacent level, adjacent to the adjacent level that I had protected. So 2, 3 went and had an ASD. I said, come on, this thing didn't work. So I put a solid rod this time, going from L2 all the way down to L5, and I was very happy about it. I said, uncle, no problem, go on, you'll enjoy yourself. Came back to me another 2 years later. This time it was at the thoracolumbar junction. I said, I made a mistake. I should have gone up to the thoracolumbar junction and beyond. So I went and jumped up, went up to D10. And I said, uncle, I've done my job. Literature states you have to go across the thoracolumbar kyphosis. I did that. Stayed well for another 6 months, came down this time with a shutdown completely. I said, oh my God, uncle, this is unusual. I've never seen a D9-10 disc pop out. He had popped out at the D9-10 level. Neurology shut down. First time non-walker, emergency operation. I said, this time I'm going to go across the thoracic kyphosis. Went all the way up to D4. I said, uncle, it's well done. This time your bone quality was not good. I'll start you on teriparatide, 2 years of teriparatide. He says, great job, son. Now I'm close to 80 years of old age, but I'll see what I can do. Having said that, he went home, teriparatide given, came back in 2 years, again neurologically shut down. Unheard of, D3-4 disc coming out with cord compression. I said, God doesn't like me anymore. Having said that, I said, now what should I do? Just screws doesn't work, I'll put wires also. So I went up to D1 downwards, all the way up to lumbosacral junction, screws and wires. I said, uncle, now this is fantastic, but I don't know what to do next. He says, son, I do. I said, what is it? He said, I'm having a cardiac procedure done soon. Don't worry. My cardiologist said, now that you're good, get the cardiac procedure done. He was 80 plus. I said, uncle, if avoidable. He said, no, I need it. I said, okay, uncle, please go ahead and do it. He underwent the cardiac procedure. Never got back home after the cardiac procedure. I don't know, probably then I smiled. God probably protected me. I would not know what to do if he had popped at the cervicothoracic junction. I still don't have an answer. And finally we come to those patients where kuch nahi hai, there is nothing wrong with them. You do all X-ray, CT, MR, contrast studies, do the electrophysiology, everything. Patient is now out of focus. It's the caregiver whose peering eyes are killing you. You lose your sleep at night because that's what you look at every day in the morning. Here all you need is advice and counseling and counseling and counseling. Depression and anxiety needs to be taken care of. You have to convert the perils of the past and remove the fears of the future by being pragmatic in the present. Having said that, what do? Listen to the patients, respect their views, have open communication about all choices, discuss all the options, let them ask questions, ensure that they have understood, be aware of their language, accept cultural influences. India, like Bangladesh, is a huge country, a lot of cultural influences, and compensate for their skills. They speak a different language. Remember, they are never above you, they are never below you. They are beside you, handhold them. In category 1, as I showed, you can correct the implants, they'll be good. In category 2, there's just a soft tissue surgery, they may be better. Category 3, you give them blocks, send them for psychological help. They never ever improve. category 3, even if you admit them, don't go home for a week. The first 2 guys feel good and go back. What do? We've used a lot of things in surgery 1 and 2. We've used tissue sealants, Duragen, lot of things have to be done, blocks have to be given. But in 3, results of 3 are the worst. Clinical and functional results. Finally, what do I conclude today? Category 1, when you revise, they are good. Category 3 are the worst. Always have a good risk-benefit ratio evaluation and proper communication. Tell them before embarking on this complex procedure that it's not something that's going to be easy. Counsel with clear intent. You can at the most be godly, never God. Do not promise them positive outcomes ever. Still you will fail. You will come down to the earth. And remember, ever tried, ever failed, no matter. Try again, fail better. I say this prayer every day, and more so when I scrub in for surgery. It's the Serenity's Prayer by Reinhold Niebuhr. And it says, God grant me the serenity to accept the things that I cannot change, courage to change the things that I can, and wisdom to know the difference. Why do we need that? Because as spine surgeons and orthopedic surgeons, all we can do is change the anatomy. We can change the structure and hope that that change in anatomy translates into a change in physiology, which means a change in function. Say the Serenity's Prayer, strive for excellence, but we do not live in a perfect world. Thank you all for a very, very patient hearing.
Thank you very much, Dr. Ramchandra. It's an amazing lecture. It's fantastic. It's very good. The next presenter.
So before that, I want to call our past president, Professor R.R. Kori and Professor Amjad Hussain, please come to the dais. And President of the Bangladesh Spine Society, Professor Shahalom, please come to the dais. And the Secretary General, Bangladesh Spine Society. Yes, sir, you stand here. We have a gift from Bangladesh Orthopedic Society for you. Okay. Yes, sir. Ashan, sir. This is both the professor. So this is a token of love from Bangladesh Orthopedic Society to Ramchandra, who is the president of Indian Orthopedic Association. Thank you. The next speaker, we have changed that after Dr. Kamrul will start, then we'll go for Arvind. Dr. Kamrul, please. No. Please, Dr. Kamrul will start this session first, then Arvind. দেব তো পরে ও যখন প্রেজেন্ট করবে তখন দেব এরপরে মিসিং লেকচার সে আসে নাই So your time 8 minutes. Your time is 8 minutes, sir. I know.
We start.
They have to leave within 11. Yes.
Respected Chairman and learned audience, my talk on clinical and radiological evaluation of cervical spondylotic myelopathy, decision algorithm. This is my university where I am working. Myelopathy is a functional disorder of the spinal cord, but cervical myelopathy is a disabling condition and most common form of spinal cord dysfunction in adults, commonly present with subtle symptoms, and symptoms range from mild dysfunctions to severe dysfunction, including quadriparesis and incontinence. Easily missed by clinician, often leading to delayed diagnosis and ultimately develop irreversible neurological damage. So now this is a scenario. A 46 years old lady came to me with neck pain and stiff leg and weakness of the upper extremities for the last 1 year. But neurological examination revealed there is no neurological deficit. MRI showed multi-level stenosis of the spinal canal without any morphological change. And this patient is treated with collar and analgesic for the last 6 months. And after 3 years follow-up, the situation still remain unchanged. What happens after 8 years? This lady came to me unable to walk without support for the last 2 years. On examination, we found unsteady gait, wasting intrinsic muscle of the hand and spasticity, and there is a hyperactive tendon reflex and positive Cronus, Babinecks and Hoffman sign. And X-ray shows there is a degenerative change, that is disc space narrowing and unconvertible hypertrophy. Dynamic X-ray revealed no instability, but MRI showed there is a multi-level stenosis of the spinal canal with cord compression, as well as myelomolecular change at the level of C5-6 at T2 weighted image. What is your diagnosis? Definitely it's a diagnosis is a case of multi-level cervical spondylotic myelopathy. What is cervical spondylotic myelopathy? It is a neurologic condition that develops insidiously over time as degenerative changes of the spine results in compression of the cord and nearby structures. Cervical spondylosis is one of the most common cause of spinal cord dysfunction. So epidemiology. Cervical myelopathy is more common in men than women. Prevalence in male age 30, 13%, age 17, 100%. And prevalence in female age 40, 5%, age 70, 96%. So what causes myelopathy? There is 3 important pathophysiological factors that develops the cervical spondylotic myelopathy. That is static mechanical and dynamic mechanical factors which causes impairment of the circulation. So come to the natural history. Cervical spondylotic myelopathy is a slow, stepwise deterioration over time with variable periods of stable neurologic function. So what is likely to be happen? 75% there may be a stepwise deterioration and quiescent stability in between and may be prolonged. And 20% gradual deterioration in functions, and 5% there may be rapid onset of symptoms as well as lengthy disability. So if no treatment is not given, what happens? 40% remain stable and 20% improve spontaneously and 40% there may be deteriorations. What is likely to happen? More recent studies, less optimistic, especially surgical papers, overall consensus, minority improve, deterioration pattern variable, and deterioration more likely if older and long duration of symptoms and severe symptoms. So now come to the clinical presentation. Most of the patients present to the neck and arm pain, but pain is absent and poorly defined. And neck stiffness, leg weakness, unsteady gait, difficulty with fine motor movements, and tasks with hands, that is clumsy myelopathic hands, loss of bladder and bowel sphincter control, and heavy feeling in the legs. And there may be radiculopathy, as well as numbness and tingling in the limbs. Sometimes patient may come to us with a chronic suboccipital headache. On examination, patient present predominantly with upper motor neuron signs, and weakness is more severe in the upper limbs. And there is a gait is ataxic and broad base, hypertonia, hyperreflexia, and there may be presence of ankle clonus. And patients, there may be muscular atrophy, motor weakness, more common in the lower limbs, sensory abnormalities, variable pattern, loss of vibratory sense as well as proprioception in the extremities, and motor dysfunction may be unilateral or bilateral. And there may be presence of long track sign, that is L-Hermitage sign, Babinecks sign, and Hoffman sign or Trumner sign, and there is a finger escape sign. Jaw jerk, Shimozu reflex, and inverted radial reflexes, gait, grip and release test, as well as hyperactive pectoralis reflex may be present. And most common is patient sometimes comes to us with a myelopathic hand, that is there is a clumsiness, intrinsic wasting, finger escape sign, grip and release test. But most important thing is that watch out for multiple sclerosis, amyotrophic lateral sclerosis, subaqueous combined degeneration, peripheral neuropathy, and tumor and infections. For this reason, you will always examine the cranial nerves as well as electrophysiological examination, that is NCB, EMG, as well as somatosensory evok potential. So, what are the imaging modalities used in workup of cervical spondylolytic myelopathy? And main gold standard imaging modality is MRI, that is which visualize the intervertebral discs, ligaments surrounding soft tissue and obtain transverse area of the spinal cord, determine the severity of cord compressions, degeneration, etc. And there is a plain X-ray, especially lateral X-ray of the cervical spine, which determines the kyphosis or lordosis and calculate the Pavlov ratio, evaluate the spinal column alignment, and as well as computed tomography with or without myelography, diagnose the OPLL, assess transverse foramen for vertebral artery compression, evaluate cervical cord compression, and obtain transverse area of the spinal cord, perform CT myelogram in presence with contraindications of MRI. And there may be electrophysiological examinations, that is NCB, EMG, as well as somatosensory evok potential. Other imaging techniques, that is dynamic MRI and diffusion tensor imaging tractography, which is recently come in for diagnosis, but not is available in everywhere. So, cervical myelopathy evaluation, clinical evaluation can be done by neuric grade as well as modified Japan Orthopedic Association score. So, now come to the decision algorithm. Patient history and physical examination, motor dysfunction in upper and lower extremities resulting in decreased hand dexterity, gait instability, and sensory loss. High suspicion for cervical spondylolytic myelopathy, go for imaging, plain radiographs with or without CT and MRI. Low suspicion for cervical spondylolytic myelopathy, work up for other neurological conditions. If there is a high suspicion of cervical spondylolytic myelopathy, go for refer to spine surgeon. And if there is a low suspicion for cervical spondylolytic myelopathy, refer to neurologist. But if there is a high suspicion of cervical spondylolytic myelopathy and there is a confirmation of cervical spondylolytic myelopathy, staging of the disease according to the modified Japanese Orthopedic Association score. If it is score 15 to 17, it is mild, and it is score is 12 to 14, it is moderate, and if score is 0 to 11, it is severe. If moderate and severe score, go for surgical intervention and refer to spine surgeon or neurosurgeon. If score is mild, go for surgical intervention or structure rehabilitation program offered. But if cervical spondylolytic diagnosis is incomplete, cervical cord compression with signs of radiculopathy but without myelopathy, go for surgical intervention or structures rehabilitation program. But if cervical cord compression without radiculopathy or myelopathy, educate the patients and follow up. Last slide, please. Take a message. A detailed neurological examination is the current standard to the diagnosis of cervical myelopathy. The hallmark of symptoms of cervical myelopathy include decreased hand dexterity, gait instability, as well as sensory motor functions. But signs are not always clear. In this regards, requires high index of suspicion, early diagnosis, and surgical management may improve neurological dysfunctions and prevent progression of neurological deterioration. Thank you. Thank you for patience, sir.
Thank you very much. Thank you, Kamrul Hassan. As the time is short, only one question is allowed. If any question. Okay. So the next presenter is Dr. Aravind Kulkarni. The Aravind Kulkarni is one of the pioneer spine surgeon in the minimally invasive and endoscopic surgery. So we are very glad to have him with us. He will talk with right now with this cervical arthroplasty. Please start your talk.
How many of you do cervical disc replacements here? Okay, which is the disc which is available here? So which is the disc, the artificial disc that is available here? Jesco, I think it was manufacturing it for a while, and then I'm not sure whether it's still on. So it's a very interesting topic, a very interesting concept. The career, so 2007, 2008 is a very interesting and exciting phenomena in my life. That is the time I started my spine practice. And that is the time when we started using artificial discs in our practice. So I had a lot of firsts to my initial career. So we did the first lumbar pro disc in India. We did the first 2-level artificial lumbar disc in India. We did the first pro disc C in Bombay. We did a lot of firsts in our unit, and it was highlighted all over the place. We even featured in Limca Book of Records. It's like a Guinness Book of Records of India. So it was a launching career for me, as well as my as well as for all the kinds of discs that were available. It was exciting and anxious because we didn't know whether these discs would move, what would happen to the concept of adjacent segment degeneration after putting this disc, what would happen to the kinematics of the lumbar spine as well as the cervical spine after putting this disc in long term. It was a matter of expectation, assumption, and procrastination, and what would happen to my practice. So initially they all moved very well, very interesting. So this was an artificial disc put at C5, 6 level in a middle-aged girl, an actress by profession who had severe arm pain, a perfect indication. So they all moved. Another patient, so this is a prestige disc. Another patient who had a artificial disc implanted, it was a pro disc. Again, it moved as you see here. A 2-level disc replacement, pro disc, it moved. Another prestige disc kept moving until they stopped moving. So these implants from discs, they become fusion devices over a period of time. They stop using and they fuse, and you can see the fusion mass anterior to the particular disc. You can see the osteophyte there. And I want you to stare at that circle above it, because the discs are basically meant to prevent ASD, adjacent segment degeneration. Then the very next slide you can see this particular disc has subsided, and the next level there is ASD there happening. You can see an osteophytes right anterior to that particular disc space above the disc. So this fusion just gets solid over a period of time. This is the reason being these two curses which are thrown on cervical discs, that is heterotopic ossification and subsidence. You try your best, they go into one of these. So how to prevent heterotopic ossification? It beats the very purpose of surgery. It's basically an expensive fusion. It occurs in close to 70% of patients over a period of 10 years. And we need to have a better handle and better understanding of this particular situation. We're basically converting a device which has to move into a device which stops moving. So how do you prevent heterotopic ossification? Your soft tissue dissection has to be very beautiful. I don't use a monopolar cautery at all when I do artificial disc replacement. It is a play of bipolar only. The elevation of longus coeli has to be with a scalpel, and it has to be very, very delicate. You minimize your bone work to the maximum. Give liberals. After every step, you give a lot of wash to throw away all the bone out. Plug all the bony surfaces with bone wax, and in certain situations when you start seeing some kind of heterotopic ossification happening, give them a course of indomethacin with due care. Again, subsidence, it's very important that you prevent subsidence. It alters kinematics, it causes foraminal narrowing, it alters facet loading, it causes neck pain and causes implant loosening. And the best way of preventing this is to keep your bony end plate intact. Just remove the cartilaginous end plate. That means you're not doing it for a myelopathy which needs corpectomy, partial corpectomy on either sides. Your choice of implant is very, very important. I'll come to the patient selection later on. It should not be placed in distraction. It should be placed in neutral mode, that the neck, basically the neck when positioning, when you fuse it, you put it in lordosis, but when you're doing artificial disc replacement, the neck has to be in neutral position because it has to flex as well as in extend. When you do a fusion, you want it to be in extended position. The best way, or the only way of preventing subsidence is to put the largest footprint disc with the shortest height. Don't over distract. Don't put a small disc right in the center where there's cancellous bone, which is definitely going to subside. And so this is one burning issue which prompted us to do this particular study, because when we are doing these disc replacements, I was feeling that on table, there was a lot of a mismatch between the patient's anatomy and the amount of the kind of discs which were available in terms of sizes and perimeters. So we did this particular study, and there was a big mismatch that we saw, and we have suggested companies to make discs basically for Indian patients with the parameters that we have suggested. So when it comes to patient selection, if there are osteophytes, if you need to do bony work, if there's narrow disc space that you have to distract, if the patient is elderly, and if there's any kind of sagittal or coronal deformity, it is a strict no-no for a disc replacement. Don't do it. You're fusing it right day one. It should be done in a soft disc herniation, that is basically in young patients, and the disc has to be tall. You should not need to distract to put your implant in. These are ways of preventing subsidence. So this is an ideal patient. Soft disc herniation, young patient, arm pain, beautiful. So another patient, 75-year-old lady, deformity in the neck, sagittal plane deformity, disc osteophyte complexes, severe OA of the facet joint, strict no for a disc replacement. Again, C5-6, C4-5, severe degeneration, no for a disc, put a cage. Another soft disc in a young patient, put a disc. Deformity with myelopathy, no for a disc, put in this needs deformity correction. You need to get your sagittal alignment back. If you look at it, if you see from far, artificial disc has smashed all over its face, right from its indication. So, when you're talking of wins and losses, triumphs and defeats, you're competing with a gold standard. The gold standard is a strong ACDF. ACDF invites everyone, all the etiologies from degen, trauma, infective, tumor, deformity. There's a very narrow corridor for disc replacement, just radiculopathy and myelopathy. So there is a defeat right from the beginning when you compete with the gold standard. Again, there is a defeat when you talk of rationale. Earlier it was made to prevent adjacent segment degeneration. That is the reason disc replacement were born. So this ASD is secondary to transfer of stress when you fuse an adjacent level. But the current literature totally demolished this particular story, and now there is growing importance to alignment and natural history as the cause of ASD. So triumphs and defeats aside, it's for you to decide. So these are some interesting facts drawn out from research papers. As far as neurological success, 5 and 10 years follow-up have shown that the neurological outcome is maintained. Kinematics is very well maintained at operative, adjacent, and overall the entire neck. So this is a 7 to 10 year follow-up, after which, as I said, they undergo heterotopic ossification. Prevention of ASD, though it says statistically significant, there is no much difference between TDR and ACDF. Heterotopic ossification is more seen in constrained discs. Constrained discs have keel which go into the end plate. But if you use unconstrained discs, they have another problem. They end in kyphosis, they displace because there is no control over them, and there are problems with execution because you can't remove the PLL if you're putting an unconstrained disc and then you're not doing an adequate neurological decompression. And the heterotopic ossification median period is about 2.25 years. That is the only time probably most of these discs move. And the last but not the least, most of the favorable studies are all market driven and biased and sponsored by these companies. So in terms of triumph is only in the thought. You saw Dr. Ramchada showed a patient where you fuse one level after the other, one level after the other. So that is not a right thing. You're converting patients into ankylosing spondylitis patients. So the triumph is only in the thought. The disc is made to move. So you need to have discs which move. We need to understand what are the problems that we face with the current discs, work on them, do research. What went wrong? What is the reason these patients undergo heterotopic ossification? Is there anything abnormal with the material that we are using, with the physiology that we are implementing into the discs? What is wrong? So we need to do research. So as famously said by Thomas Alva Edison, I haven't failed. I have just found 1,000 ways that won't work. So in young patients, I believe young patients are still an indication for me to do artificial discs. I hope they keep moving. And the impetus should be on research to get discs which move forever. Thank you.
Dear Kulkarni, please you continue your another lecture, please. Second talk.
Not coming. Not coming. Yeah. Okay. So thank you for your patience. So this is the prosperous India that you see on this slide. I'm not shaming anybody. So India is prosperous now. It's one of the top developing countries that shows in this particular patient. He's a 150-year-old gentleman, but a small ant is biting him at L4, L5. He has severe leg pain of almost 4 months duration, and he cannot lose weight or try any kinds of other medication to take care of his pain. His pain prevents him from walking, doing anything. So the best solution is the minimal access discectomy. This was done using a 14 mm diameter tubular retractor, and he walked majestically after a few hours of surgery. So if you see here, it's just a small fly on the wall that you see here. So that is the core of minimal access surgery. And again, can you imagine doing this particular case? Severe stenosis, you can't see the dural sac here, and using a small 16 millimeter tube, you can achieve an excellent decompression. This is post-op. The canal is very well decompressed. You can look at the soft tissues. The soft tissues are left intact. The spinous process is left intact. The bony anatomy on both sides is very well left intact. And over a period of time, this hole gets filled with bone. So minimal access has a big role to play in in getting such patients out of their problem. Again, so this patient has 3-level stenosis with listhesis, lytic at L5, S1, degenerative at L4, L5, and a little bit of a retro at L3, 4. She is a host, she is a baggage of comorbidities in terms of everything, obesity, diabetes, hypertension. She takes these blood thinners, etc. Extremely moribund. And look at the beauty of minimal access, decompression, stabilization using minimal access, using the same tubes, percutaneous screws and implants. It's very hard to pinpoint where the scars are. Wound healing is one of the best gifts that MIS has given us. Open surgeries, 2 out of 10 wound, develop wound problems, and I need to call a plastic surgeon in my practice. This is another beautiful case where the patient has a migrated disc coming from L4-5 down, and also has a L5-S1 lytic listhesis. One is in the axilla, one pathology is in the axilla of L5, and one is in the shoulder of S1. So we do a discectomy using the tubular retractor and a fusion from discectomy of the axillary disc and TILIF from the shoulder to achieve a stabilization. Another patient with this is a terrific combination of navigation and minimal access using the tube. He has a deep-rooted osteoid-osteoma in the right S1 pedicle using a combination of navigation and minimal access. So the tube is placed right on top of the trajectory of the osteoid-osteoma. So as we drill down, being guided by navigation on the monitor, we reach the osteoid-osteoma. You can see we are in the direction of the osteoid. Otherwise, it is impossible to remove this particular lesion from this broad sheet of bone. How do you reach there? Not only can you excise the nidus, You can do a navigatory spin later on and again check whether you excised the lesion or not, and that is using a minimal access. The patient went home the very next day after surgery. This is an elderly patient, again a host of comorbidities, severe comorbidities, not fit for a prolonged surgery. She undergoes a 3-level decompression, so she has stenosis from L3-4 to L5-S1. But just by redirecting this particular tubular retractor. So using one hole, which is here, we could decompress all the 3 levels. And so you can do these discectomies using these tubes under local epidural anesthesia. So the patient is just on oxygen, and I've been chatting with her throughout the surgery. So her husband is a real estate broker. I was asking the tariff, the price of a square feet of her flats. So this is a patient who had undergone laminectomy. So you can see this long incision which had healed with secondary intention. So this is facet effusion. There is no inferior facet left here. Patient landed in instability the very day of surgery. Didn't get out of bed. Again, who would go through this scar which healed after 4 months? So look at this instability which is produced iatrogenically. So these are the holes through which the surgery was done. So percutaneous screws through these holes, a TILIF procedure through this particular tube. So these are the scars of the revision surgery. How many would dare to go through the same scar here in the audience? It's a tough job. And imagine doing a spondyloptosis with these scars. This is a case of spondyloptosis. It's unimaginable to do even open sometimes. That can be achieved with minimal access. This is another patient with grade 4 lytic again operated through the tubes. You can see in the CT how well it is reduced. So all done percutaneously using screws and tubes. Again, if you have kissing facets like this, if you go from the same side and attack this particular disc, you will excise the facet and cause instability. So you go from the opposite side. These are the principles of MIS. You go over the top and remove the disc of the opposite side and maintain the integrity of the facets. So minimally invasive surgery can be defined as a procedural approach that by virtue of surgical technique results in less collateral tissue damage, decreases morbidity and provides patients with a more rapid recovery relative to traditional procedures with the smallest footprint. So what are the pillars of MIS? Target, technology, technique, training, testing and talent. So what do these T's mean? So target means choosing the appropriate patient and appropriate procedure. So if you're doing a MIS discectomy, you need to have the right patient, you need to have the right procedure. You need to have the technology, you need to have a microscope, you need to have a C-arm, you need to have a drill, you need to have your tubular retractors in place. And you should know technique, you should know how to do this particular procedure. Training is basically how well you're trained in doing these particular procedures. And testing, after you do these procedures, do your own audit and see that are you doing it right. Unless you do your own audit, you won't progress. And talent is build on it, teach people, propagate it. So this is testing which has come out of our own experience. And at the end of it, don't compromise. So stability, alignment, biology and function has to be maintained, has to be restored. So the take home is, buy these tubes and scopes. And I, on behalf of Bombay Spine Society, as well as Dr. Ayush, who is the organizing secretary of this particular mega conference, invite you for our SMIS AP conference. This is an international conference held under the aegis of MISAB, that is Minimally Invasive Spine Society of Bharat, and BSS, Bombay Spine Society. And we are hosting this particular society, which is the Minimal Access Society of Asia Pacific, which is a sister of Society of Minimally Invasive Spine Surgery, US. Thank you.
Thank you very much. Now I'm asking Dr. Ayush Sharma for his presentation.
find it. Presentation is not here. Yeah, someone can help me with this. My presentation is not uploaded. Okay, it's not the pen drive.
Do you have anybody having these questions to Aravind Kulkarni? Please go ahead.
So thank you for your excellent presentation. So my question is regarding high-grade spondy. So in case of high-grade spondy, suppose the pelvic incidence is more than 60, spine is balanced, pelvis is balanced, so you can do it by MIS. So in cases where the spine is not balanced and pelvis is not balanced, so in that case so far we have to extend more and spinopelvic fixation is needed. So in that case, do you still consider MIS in that particular case?
No, if it is unbalanced, you don't have to extend further. I've never gone beyond L5 unless I'm probably in my last 17 years of practice, I've never gone to L4. I always stopped at L5. L5S1 listed is corrected at L5S1 alone.
So when the spine is not balanced and pelvis is not balanced.
No, that is because
so
that is because there is listhesis.
Okay.
So once you correct your listhesis, your alignment is back. Never is it advocated that if it is unbalanced, you need to go higher up.
No. So, but as per even we go through the AO guidelines, it is clearly written that so in case of unbalanced pelvis, you have to go far behind.
Not necessary. If you are able to correct your L5S1 lytic listhesis, if you are able to reduce it, basically there is lumbosacral kyphosis.
Yes, lumbosacral.
In all cases where we had lumbosacral, all cases of spondylolisthesis, we restored the I'll show you the parameters. We have restored lumbosacral lordosis. All of these. Once you achieve get your lumbosacral lordosis back, you achieved your balance. You don't have to go higher up.
My second question is, so in such cases, suppose in case of high-grade spondylosis, it is very difficult to put the pedicle screws. So is there any tips or tricks can you just share? How can you?
So one is navigation.
Navigation.
One is navigation.
We don't have navigation.
Out of these 5 cases, only in one patient did we use navigation.
Okay.
So it is very, so I think we are
okay. Thank you, sir.
So at the behest, thank you Bangladesh Orthopedic Society for having me here. It is my second trip and I do enjoy your lovely country and I have many good friends here and some of my fellows as well, so it's a wonderful experience. So let me start with this case, sort of opened my eyes to cervical myelopathy. This 60-year gentleman presented with quadriparesis. You can see there is significant cord change happening in cervical spine and the power was 3/5. We felt the best way to deal with it was do a posterior laminectomy and lateral mass fixation. And you can see it looks like a good decompression. And you can make out from the C-arm image, it is an old case. And this is what we could achieve. I was very happy with what we did. I thought I did a good job. But post-op was eventful. But then he presents 1 month after surgery with power 2/5. And you can see something happening in the spine cord on the post-operative MRIs. And this is a 2-year follow-up and see what has happened to his cord. In spite of our best judgment and best we could offer, patient has gone downhill. And that led us to thinking what could have gone wrong. And this is an award-winning paper in North American Spine Society which we presented. And we realized that if you don't keep your intraoperative blood pressure at a certain level, you could cause a intraoperative damage to the spine cord. And what we recommended at that, for each and every patient of cervical myelopathy, you should record your preoperative mean and maintain it 10 millimeter of mercury higher. Over a period of time, we went on and published several papers in cervical myelopathy, and these are some of it from my institute. And this topic is based on this paper, which we published in 2021, which is the current trends in degenerative cervical myelopathy. This is based on the research
and the review of literature which is presently available. With this, I bring to my talk on recent advances. I'm Dr. Ayush Sharma from Mumbai, and it is again a pleasure and privilege to be here. So if you look at the advances in imaging, this is one of the biggest advances which is coming in cervical myelopathy. Your MRIs are becoming better. You're having a 3 Tesla MRI now. You are having a flexion extension MRI now. Someone was talking about DTI. So it is allowing you to diagnose these patients better. There is $1 million question. If there is anything beyond surgery, is there a medical way as well to treat this patient? And these are some of the research which has been done. Tablet riluzole was extensively researched by Michael Felling, who is the biggest name in cervical myelopathy research. Unfortunately, it didn't serve that well. And then came this molecule, which we thought was very interesting. It is called cerebrolysin, which has a neuroprotective, neurotropic, and neuroregenerative properties, and is very, very well used by neurosurgeons in stroke. And we published our first paper in Spine Journal, where we recommended a 21 days therapy for cervical myelopathy. And it does lead to a better outcome in our cases. But the problem was 21 days is too big time to give. Then published a second paper, again in Spine Journal, and we recommended a 10 days therapy after surgery in cervical myelopathy. And there was a 67% neurological recovery in patient who came with deficit. So that was one of the most important findings of the paper. And when it comes to, in decision making, the K line has been one of the most important criteria to be followed. If you are doing cervical myelopathy cases, you should understand what the K line represents. And using the K line, you can change the decision making. So you see a case like this, where this is K line negative, that means you have to go anterior for sure to get the pathology done. But we went ahead with doing a 3-level ACDF. So what you did, you shifted the K line. By shifting the K line, the whole pathology has shifted. And this is what is one of the novel techniques which can be done when you are treating with these cases of cervical myelopathy. We all know anterior approach is best to deal with pathology when it is anterior, but this is what we have been doing for quite some time, which is an oblique corpectomy. Instead of doing a complete corpectomy, you go with the oblique approach, and you can really get the job done. Even in cases where you have a significant osteophyte, you can do an oblique corpectomy, and instead of doing a complete corpectomy, you can get away with a decompression. So we all know, irrespective of what you do, a good decompression is paramount, and that is what it takes. But it's not always easy to do good decompression, especially if you have a myelopathy is going up to C2 or C1, and this is where these technology and recent advances come into picture. What you are seeing right now is ultrasonic scalpel, and it is very, very safe. So what you are seeing is, I am cutting under the C2, and it is so safe to do it because it just cuts the bone. It doesn't damage the dura at all. And this is what you can see, a good cord fallback. And this is the post-operative outcome. I'll just skip few other slides for the sake of time. And then the role of MIS. MIS is also coming in a big way in cases of cervical myelopathy. You can do it endoscopically. You can do with tubes. What is the future direction? Robotics is coming. In difficult cases, you can use robotic. Navigation is always a good thing to use, and this is what we have been using. This is a navigated ultrasonic scalpel. We navigate our ultrasonic scalpel. We fuse the images of MRI and CT, and this allows us to do a very, very precise and particular cut in case of cervical myelopathy, and that is what you see is being done here. And look at the images and the cuts you get. And these are the post-operative MRIs. You do exactly the cuts you won't need to do using the navigation ultrasonic scalpel. So in conclusion, the treatment and advances in cervical myelopathy is ever changing. It is important to understand these changes and to individualize the approaches using all the technology that is available to us and to make a better outcome for the patients. Thank you so much.
Thank you, Ayush. Could you start your second talk, please?
Yeah, I'll do that. So for the sake of time, they've asked me to continue with my next talk, which is on endoscopy. And between myelopathy and MIS, these are my two favorite topics. So thank you for allowing me to share the experience for both of it. It's just loading. So endoscopy is again something, Arvind was just talking about tubes, and I am on, even on the other end of spectrum, I'm very, very passionate about endoscopy. So let's skip the introduction, it's already over, at least we can save time for one slide. So when it comes to endoscopy, there are two ways to kill this pathologies. You have an interlaminar approach where you go inside the lamina using the interlaminar window. The advantage of it, all are familiar with this interlaminar approach, and it's a very, very versatile approach. But please understand, look at how the interlaminar window changes from down to up, and that is how your approach and ease to do these approach changes. So it is very, very good if you have a case like this. You have an extruded L4-5, L5S1 disc on the lateral side, and you just need to use the interlaminar window. This is how beautiful you see the nerve root. You retract the nerve root, and you do your discectomy, and that is how interlaminar approach is. And not only that, you can do a discectomy. Look at this patient. He has significantly superior migrated disc. And this is how she comes to us with a complete foot drop. And we went ahead with the interlaminar approach. This is how it is. And this is the beauty of endoscopy. This is how you see everything so crisp and clear at the end of the discectomy and the end of decompression. And there are 22 disc fragments that were removed from this patient that day. And this is a post-operative MRI. You can see it's a complete job. A small incision doesn't mean that you don't do the job completely. And even if you want to add a decompression, interlaminar approach is the best way to do it. Again, there's another way to do these things, which is a transfemoral approach. Now, this is a unique and interesting approach, because what you do, you go through a transfemoral window, which is not very commonly used by orthopedic spine or neurosurgeon. So it is very important to understand this window, this anatomy. So this is what you do. You go through a Cambian triangle. You bypass the exiting route, and you go into the disc space and do your job. Again, the anatomy and the pathology is determined by the levels. If you see, to approach each and every level, there's a different technique and slight modification in the technique as you go ahead. It is best suited for something like this, which is extraforaminal disc, which is very, very difficult to tackle, even with a tubes or an open surgery. But imagine something like this. This is almost a difficult case, whether you open a tubular surgeon, but someone who comes with a central, very central disc, right at the L2-3. But for transfemoral approach, it is a very, very easy approach, because you will directly land at that area. You go exactly at that place. It is like a targeted approach. You target the disc without taking out anything from posterior, and you get your job done. And that is the beauty of this approach. Even in a difficult situation like this, it is one of the best things you can do, and that is what was done here. What you see is the disc fragment just coming out using a 0.8 centimeter incision, and that is what you have, that is being done. You see this is the disc fragment, and this is what it looks like. So, this is not from disc, but this was a patient of discitis, and she is unfit for any anesthesia because of her lung function. And again, this is what we did. Look at the decompression and look at the pus which comes out from this patient. This is patient who cannot be operated under GA. You cannot do anything. So we did under local with an endoscope, and this is what you can achieve. You achieved a decompression. We did a bone grafting as well. We pushed the bone graft through the same funnel. As you can see, we did the discectomy, took the samples, did a debridement, pushed the bone graft, and this is intraoperative CT. You can see how nicely the bone graft is fitting in, and the samples comes out to be Mycobacterium tuberculosis. In cases like this, where you have a foramen disc and osteophyte, what we do is we use navigation. We use a navigated drill to drill the osteophyte. Now, something like this is a nightmare for anyone. It's a calcified high-level D11, D12 disc. But when you are endoscopy surgeon, it opens a new frontier to you. You can tackle everything through endoscopy. So this is, you are drilling the calcified disc using a endoscopic burr, and once you drill it, This is you can see the demarcation between dura and the disc, how beautifully you can see this even in a difficult case. And this is the and this is the end of the discectomy. You can see how the dura is free and how it is fluttering, and that is what you can achieve when you are endoscopic surgeon. But it comes with some complication and limitation. Endoscopy is not the part of the training which we give to our students. It has to be incorporated. The instruments are costly. You have to consider that. It has a long learning curve. But you know, this is where we are. Just like your mobile phones are changing, my surgery has evolved over a period of time. From what I learned from my master, Dr. Ram Chadda, who is sitting here in 2012, to what I did when I got inspired by Arvind Kulkarni in 2017. This is where I am today, doing endoscopic surgery. And this is the beauty of endoscopic surgery. This is a complete decompression. And you see everything is intact. Your whole ligamentum flavum is intact. All the muscle are intact. And when you pull out your sleeve, layers of muscle fall back because you have not removed anything to get the job done. And that's what I believe is minimal incision and maximum intervention. So it all exists only in mind, and only in its mind it can be overcome. So it's just a mind block. If you want to become an endoscopy surgeon, you can do it, and that is nothing preventing you from doing it. And with this, again, on behalf of Bombay Spine Society, and me and Arvind will like to welcome you to join us if you want to know more about tubular endoscopy or anything in MIS. I hope I kept to the time. It's less than 7 minutes. With this, I thank you all, and I will appreciate all your welcome and your gesture. I always have very, very good time here. Thank you.
Thank you, Ash. I'm sorry, it's a very interesting lecture, but maybe you have a lot of questions, but due to some inconvenience, due to shortage of time. So as they are living together in the same flight, I'm requesting Tonai Prabhu for his talk regarding the daycare spine surgery. Please, Tonai.
Hand and arthroscopy session started in the second floor, hall number 2 and 3. Those are interested to go and join this session.
As it is taking little bit time, is there any burning questions to Ayush Sharma for endoscopy? Yes, please.
Yeah, so you know, the good part for transform you're asking. Yeah. The good part, interlaminar. So basically the best part is the visualization. You have such a good visualization, and you have hydrodissection. Because so once the water goes, it dissects the path for you. So for the sake of time, let's keep it there.
Yeah. So very good morning to one and all, and thank you BOSCON and Bangladesh Orthopedic Society to invite me and be part of this prestigious session. It's really great to be back in Bangladesh almost after a decade. So Dr. Arvind sir as well as Dr. Ayush has made all this very, very easy, and they have already spoken of minimal, and that's what is my also talk. And the familiar story so far, we always know that spine surgeries have got long scars, long stays. The disability of fear is always there in all the patients, and mind always has been and always is there, but we are trying to make it much, much better. Uncertain about the future and results, and prolonged dependency is always there. So these are the major points which are there. So let's talk about daycare spine surgery. As the things are getting evolved, it's becoming much faster, easier, and even shorter. The stays are becoming shorter. So that's I think Ayush can just answer the question till then. I just load.
Yeah. So basically, what I was telling is, if you go through a transfemoral approach, interlaminar, two thing happens. Endoscopy, your visualization is excellent, and then you are doing a water medium. There's always if you cut the ligamentum flavum, the water goes, so it creates a plane for you, and that is the beauty. It is a safety mechanism, and that is how it works. Okay. So, and the visualization, if you see, is changing every day. You have a LCD screen, you have LED, now 4K. So the better the technology gets, better is your visualization every 4 years. That is how it is.
Copy it, don't outside.
Anything you ask us.
Copy this. Yeah. No, copy the whole folder. Yeah. Paste it outside because this pen drive is not working. And it is working.
Yeah, it's a very interesting question, okay? So say there are two ways to look at it. If you are an experienced surgeon, I will suggest start interlaminar because you already are aware of the anatomy. But if you are a beginner, it is easy to start transfemoral, considering that transfemoral is an easy job because your scope is fixed in the anatomy. You don't need to move it. So it makes your life easy. But understand, it's a different anatomy. Not a difficult anatomy, but something you are not aware of. Okay? So this is how I always tell. I started with interlaminar because by the time I went into endoscopy, we have done a lot of tubular and open surgery. So, yeah. Thank you.
So, great. So we come back. Sorry for the delay. So daycare spine surgery is the future, and all these procedures are done almost like in outpatient or daycare procedures. We all know about the common spine pathologies which are there, the degenerative spinal issues, the traumatic injuries, infections, deformity, tumors, and the more complex ones which are the occipital cervical surgeries. And we'll focus on the degenerative spinal issues which are there. The common ones which we are aware of are the lumbar canal stenosis, the slip disc, the spondylosis, the listhesis, vertebral slipping, as well as the osteoporotic fractures. We have to do decompression and as well as reconstruction usually in all these cases. But as we say, we have to keep on planning the event, otherwise you fail. So planning of the event is right from the beginning. All the pre-op workup should be done on the OPD basis almost many days prior, unless it's an emergency. Nowadays all the anesthetists also are quite involved, so try to show that all your patients to the anesthesia department much before so they can clinically see as well as see the imaging. Date of surgeries can be well in advance fixed and booked, and nil by mouth overnight, as well as analgesia or Alprax or something can be given in the night, so it keeps their mind very calm and clear. Admit on the day of the surgery itself early in the morning, do the surgery, and then you can discharge nowadays even in the same day in these procedures like MIS, endoscopy, all these can be sent within the next day itself. But behind the scenes of these surgeries and all are not only the surgeon, there are so many other things. The radiological advancements have become so well in today's time in our country as well as Bangladesh. The Tesla machines have become better. The intraop imaging, the C-arms have become better. The Indian ones also become much more, and the local ones have become cost effective. The OT facilities, nowadays you cannot say that it has become a luxury. Light source has to be there. I remember doing my initial training, and even Ram Chadha sir, even today, had told me that you need the loops, the headlights, and I still use it right now for all my surgeries. It makes a big difference, and I would recommend all the youngsters to do the same. Surgical techniques have evolved over time. Endoscopy as well as the MIS have come. Anesthesia techniques have also become better, and if the anesthetist gives you a fantastic field and give a good hypotensive anesthesia, it makes your life very, very easy in a major surgery. So preemptive analgesias, the less relaxants, short antiemetics, and the inhalation desflurane has made the clear headache wake up is very, very good. So before even going for the surgery and all planning, you have to see how the patient will position, where the table is, how the C-arm will go. So that is very, very important. If it's a dorsal level and the metal thing is coming in between, you will be stuck up. So localization is very, very essential, and see that all your C-arm is functional. Nowadays all these things have come, the retractors, this tubes, and that is what is the future, and we are talking about, and even now the endoscopy has come. The microscope is a huge tool. Most of the bigger institutes definitely have it. The incision becomes much lesser. The lighting is much better. The hemostasis can be maintained and very quick. The tissue differentiation, which is very essential, the ligament flavum, other things can be easily made out in a microscope. And these easily, daycare surgeries can be easily made. One level decompression, discectomies, even ACDF can be easily done. These are the surgeon's fate in the instrumentation. Once you have that, you can achieve anything, and even such procedures like one level fusion surgeries can be easily done. Gradually from open surgeries, we are going into the era of minimal invasive fusion surgeries, and these are the imaging, how it is traditionally been done. I'm sure most of you all are doing this right now also. And see the scars, the incisions have become much, much smaller, can easily achieve the same thing by the minimal invasive approach. You preserve the midline structures. That is the importance. So the posterior structures are well preserved, and it helps a good support, which is very, very essential. The microscope, very, very helpful. Illumination, and this can be easily done with that, and the image intensifier. You have to know how to keep the setup very well, so it makes the life very easy. It never misses. This is all the incisions, just showing the traditional as well as minimal invasive scars which are there. It is an exciting option which is going. The costs are, though it is high, it is gradually reducing. Local companies are making these things, and it's very, very helpful. The imported ones are still expensive. Indications have been refined, so you have to be careful where you have to use it. But I think gradually we are able to do all these cases in the minimal invasive manner, as well as now endoscopy. Another pattern and important factor which is very useful for daycare surgery is in osteoporosis. As we know, the fractures heal with collapse, and you can see in 3 weeks, 6 weeks, all these are usually conservative line of management is the first line of management which is done. But you may find in some cases there is non-unions, and that is where there is severe pain after even 6 weeks. And this old man, when you are lying down, he feels all right, but when he is made to sit up, immediately he feels the instability. So I would recommend you to always do the x-rays in lying down supine as well as in the sitting position, so you can see the dynamic instability which is present, and the MRI which shows the non-union area, which can be easily filled up with this gap with the help of cementing, that is vertebroplasty. And you are aware this can be easily done in the local procedure. This thing can be inserted, and cementing can be done with, you need just 1 or 2 ml cc of the cement, which can be available, vertebroplasty cement, either in the same side or in the both sides. So this is the image guided C-arm final picture. And after the procedure, just after surgery, you just have to give 1 dose of antibiotics after 6 hours. Make the patient walk the same day in the evening. Discharge maybe in the same day or the next day in a reclining position in the car. Analgesia and vitamins can be given as supplements. Waterproof dressing can be done, so the patient doesn't have to be worried. It can go for even bath. Absorbable sutures can be used instead of using the normal Ethelon or staples. Follow-up dressing can be done after 3 days. Avoid squatting or bending for a month, and resume light duties after 2 weeks. So the advantages are many. It gives a very big confidence booster to the patient, the relatives, to do that day. Less muscle dissection, very, very less infections, and because the hospital stay is reduced, and less cost. And it definitely helps the hospital itself to get the revenue and turnover also. So the take home and carry home messages are, daycare surgery is a reality today. I think it's a win-win situation for the patient, the relatives, everyone. tribute to the multi-speciality, the radiology department, as well as your anesthesia, and this advanced surgery really helps. Thank you very much for a patient hearing.
Thank you, Tanai. Thank you very much. So due to shortage of time and they are leaving, they have the same plight. So I'm requesting Ramchatra, just give some concluding comments of your side.
Thank you very much. It's been a pleasure, and three of our young stalwarts are on their way out, Dr. Arvind Kulkarni, Dr. Ayush Sharma, and Dr. Tanay Prabhu. May we thank them all for being here. I'm the only one they are leaving behind because they are minimally invasive surgeons. They are very busy people. I'll stay on, and I'm going to be here with all of you. So thank you for inviting us. They have all come all the way from Mumbai, and God bless you. We have BOS in Bombay called Bombay Orthopedic Society, and we have BOS here, which is Bangladesh Orthopedic Society. And somewhere there is a connect, so we look forward. Thank you so much. Yeah, you need to be... Tanay, yeah, all yours. So safe flight, safe journey, and great time, guys. Thank you. Bye-bye. Let them go. After you. I'm good. All the best. Run, run, run. If aircraft doesn't wait, go.
Sir,
So we are...
Time announcement of best paper session. Who is the winner today best paper award? I am requesting Professor Imamuddin sir, please come to the dais.
The rest of our paper will be presented with this after this announcement. Please be seated here.
Let's say farewell to the sorry, departing surgeons. We say goodbye to the departing surgeons and good morning to each and every one present in the hall. We are waiting for a result of the best paper presented this morning. This is a special venture taken by the boss leaders and the organizing committee of BOSCON. 6 papers had been presented. All these papers we enjoyed a lot, and we had been 6 judges. All the judges were so amazed, so happy to see the presentation, the mode of presentation, the preparation of the papers and presentation, everything was so appreciating and appreciated well by all the 6 judges. I must say thanks to all the presenters, all the 6 junior surgeons presented these papers. Right, sir? Now waiting for the result, 1 or 2 points to the presenters. Since you are too young still, young enough, few points to be noted when you present your paper. You have marked this time from the experienced presenters, how do they agents. But I especially, this morning, I especially really thank from core of my heart, the boss leaders, the organizing committee, for preparing them and for selecting these papers which are made, which are prepared so extensively beautiful, exquisitely beautiful. The mode of presentation we have marked much more improved. The subjects selected much more improved. So I must congratulate along with the presenters and their guides also. All the papers, they secured nearly the same marks. The judges are in problem. Who is going to be first? Who is going to be second? All the papers are highly appreciated by all the judges, along with the mentor who came a little late, Professor R.R. Query. So we all decided, after all, after a great deal of thinking, after a great deal of joy, the result came out. I will say the name. One paper has been selected to be the best. It doesn't mean that the rest 5 papers were not beautiful. It is, this is the best, all 5 papers were better. This is better than the best. So the best paper selected was presented by Mr. Dr. Ziaul Hassan. Let's have a... May we congratulate Ziaul Hassan for his best paper presentation. Ziaul Hassan, yours? May I invite all the 6 presenters to be on the dais, please?
6 presenters.
May I invite all the 6 presenters to be on the dais, please? সবাই এত ভালো পেপার করছে আর আপনারা এত সুন্দর করে করছেন এবার সিলেকশন এত সুন্দর
আপনারা আছেন আপনারা থাকলে কোনো ই থাকবে না
So now we are going to start the session, the paper, rest of this paper. Now I'm requesting Dr. Gururaj to present his paper, please. Go ahead, Dr. Gururaj. So the other presenter is Professor Shalom, Professor Anwarul Islam. Please, yeah. After this, Gururaj.
Can I have my talk, please?
Is there any problem, Gururaj?
Actually, I think he has not.
We have no tea break time, but tea and snack is ready in the service building. Already? Okay, sir.
Okay. Good morning again. I once again thank the organizers for having me here. And I'm going to introduce to a new concept today, that is in a cervical spondylotic myelopathy. How does a dynamic MRI, that is flexion extension MRI, does change your decision making, and how does it help actually? So we all know that for any spinal purposes, before you decide on operating, you need to get an MRI done. How does the dynamic MRI help? What does dynamic MRI mean? Dynamic MRI is you do a MRI in 3 positions, that is neutral, flexion and extension. And a recumbent neutral MRI gives only a morphological detail. So what is the static compression which is happening there, and may not always correlate with the clinical symptoms. Like this in MRI, if you see, there is a hyperintensity zone. So there is a hyperintensity zone there, but there is no compression. So how does it happen there? So that is how your dynamic MRI is going to explain you. And there are significant false positives and false negative rates with this. It does not really reflect the physiological forces experienced by the discoligamentous structures, which are not exactly causing the compression in an upright or a neutral MRI. So these are the 4 MRIs, just remember these. We will discuss these MRIs in future, and then you will know exactly how does the dynamic MRI change your thinking process. So this is what happens in a spondylotic cervical myelopathy. These are the compressing forces, that is retrolisthesis. There is a bony osteophytosis, I might be anterior or posterior. There might be multiple disc herniations, laminar impingement, and ligamentum flavum buckling and hypertrophy. This is what changes when you do a dynamic MRI. So it is just an example. You see a post-laminectomy MRI, but then this patient develops post-operative neurological worsening. So what is the explanation? Explanation is this. Whenever he is extending, his muscles are prolapsing into the canal, and the muscles itself in extension causing the compression, causing neurological deterioration in this patient. So when you are not able to explain why something is happening, the dynamic MRI can give you an idea why that is happening. So we'll just skip. This is how you do your dynamic MRIs, at least 1.5 Tesla MRIs, and it does really tell you about buckling of ligamentum flavum. It does tell you about vertebral retrolisthesis, and it causes major causes of dynamic compression in cervical myelopathy. So this is the grading given by Mule, and grade 0 to 4. 0 is no compression. Grade 1 is there is a canal narrowing, but there is no impingement. And grade 2 is either there is a anterior impingement or a posterior. There's only one impingement. Grade 3 is there is a impingement from both sides. Grade 4 is you have a cervical myelopathy. So that's a study which was originally done to classify these grades, that they found that during flexion there was narrowing of 43% of the ventral space and widening of the 89% of the dorsal space. Again, during extension, the dorsal space reduced by 17% and the ventral space increased by 9%. Stenosis gets significantly greater in extension as compared to neutral or flexion position, and patients with degenerative changes with multiple segments are more likely to express a dynamic compression. That is what was their thing. Next thing was even if instability, we think X-ray will give us a very good idea to identify the instability, but again they found that the X-ray instability was only in 25%, and in MRI, the instability they could identify in 54% of the cases. Grade 3 functional cord impairment, that is where all the cord changes start at the grade 3 level. So you see that at extension 37%, that is 74% of the MRIs or at levels showed compression as compared to in flexion only 6 patients. So this is in the same patients when you do a flexion extension MRI, so that is what was found. Again, coming to basically a hyperintensity lesion, you see what happens is sometimes we do an surgery, and then after surgery we see hyperintensity zone in the spinal cord, and then we start blaming ourselves, saying that during the surgery with the Carrison rongers or with the manual compression, the hyperintensity zone increased. But in reality, if you do the same MRI in flexion, you will find more hyperintensity zones preoperatively itself, because in extension or a neutral MRI, hyperintensity zone tend to get obscured. But in the same patient, if you do a flexion MRI, you will see more number of hyperintensity zones which are pre-existing rather than postoperatively developed. So that's false, basically the missed dynamic canal stenosis. You see in extension, almost 16% was the rate, and in only flexion it was 3.7%. So in conclusion, they said that basically the missed dynamic stenosis in extension happens due to larger disc bulge, severe disc degeneration, greater angular motion, segmental kyphosis, and developmental stenosis. Again, dynamic MRI also showed that if whenever you have a more than 20 degree of motion between C2 and C7, it's better to fuse these spines when we do a cervical spondylotic myelopathies. Rather than just doing a laminectomy, or rather than just doing a laminoplasty or a motion preserving surgery, if your motion is more than 20 degrees, you should go ahead and fuse these patients to have a better outcome. Again, I will just skip. In dynamic MRI in CV junction also, it really helps you in a minor or a stage 1 type of basal invagination. When you see your extension MRI shows that your spinal cord is getting cleared of the odontoid process, you can just go ahead and do a OC fixation with maybe a C1 arch excision. So that should be enough rather than distracting or putting a spacers into the C1, C2 joint. So again, dynamic MRI helps you in identifying CV junction pathologies. The other most important pathology which you can identify is a Hirayama disease. Hirayama disease is a flexion disease. This is the one disease where the compression increases in the flexion rather than in the extension. And you also should see for the spinal atrophy, which is visible again in flexion, and detachment of the dorsal dura from the basically dorsal dura from the cord, and epidural venous congestion, which you can clearly see in flexion MRIs. So this is our study which we did in our institute, basically with mule grades again, with 1.5 Tesla MRI. Around 100 patients were studied. We studied our cervical lordosis, anterior and posterior cord lengths, and spinal cord area. And we also saw for anterior cord length and the posterior cord length in flexion and extension and neutral positions. And totally 100 patients were studied, 34 females and 66 male. And there was significant difference in flexion extension to neutral to extension in mule grades, cervical lordosis, spinal cord area, and cervical cord angle area. I will just not go into the values, but you can see that they were all significantly different as compared to flexion and extension. The most important the difference is this grade 2 and grade 3 levels significantly increased in extension, which actually changes your plan. I will show you how does it change your plan in future slides. So that was the conclusion, that basically extension, the stenotic levels do increase. So you remembered these 4 cases. Let's see one by one. So that's the case number 1. You can see only a small hyperintensity lesion. There is no compression happening whatsoever, and you get confused whether this is a traumatic or something. But then if you do an extension MRI, you see that definitely there is a 3 levels of compressions which is happening in extension. This is what is causing the problem. So ultimately you change your decision and go ahead and do a posterior surgery. Again, the second case, that's the second case. You can see C5, C6, C6, 7, there is a compression. But then if you do a flexion extension MRI, C4, 5 is also seen to be causing compression. In these cases, if you just go ahead and do an anterior, they will come back with C4, 5 level cervical myelopathy. So again, we had to do a posterior surgery here. That's the third case. Again, if you see, there is some cord intensity changes at 4, 5. But if you do flexion extension MRIs, you see all levels are subluxating there. C4, 5, 5, 6, 3, 4, 6, 7. And in extension, there is a ligamentum flavum buckling also. So in this case, if you see, if you go back and just based upon this, if you do surgery, you will do only surgery in this level. But ultimately, if you do a flexion extension MRI, you know the only one level surgery will not suffice in this patient. And again, you will have to do a long fixation and decompression in these patients. Next is this patient. Again, there's no compression, only cord atrophy you can see. And patient does present with all the signs of cervical hand myelopathy signs. So what is happening there? Again, if you see, that's what is happening. Dorsal dural separation, venous congestion and cord atrophy, and it is actually impinging anteriorly onto the disc. So these patients do require a long segment fixation or a anterior surgery in these patients. That's a Hirayama disease. So what is the need for dynamic MRI? To look for changes in the spinal cord and spinal cord dimensions during flexion and extension, assess instability, and whether there is any discrepancy between clinical examination and radiological abnormality. You feel that there is a neurological level is at around 6, but then your compression is 4, 5, or whether it is neurological level at 4, 5 and your compression is at C6, 7, when you are not able to comprehend, when there is a dilemma of choice of approach, whether you want to do an anterior surgery or a posterior surgery. So it is definitely will dictate your surgical procedure, a number of levels you fuse, number of levels you decompress. So it's very easy to do. It is not a very difficult thing to do a dynamic MRI. If you go and talk to your MRI technician and just teach him in 2-3 cases, you will be able to get it done. In our institute, we do it in all our CV junctional anomalies and all of our spondylotic cervical myelopathies. I think that is the way to go forward. Thank you.
Thank you. Thank you. Guru Raj, I have a question to you. Do you know that this is when the patient is having the cervical myelopathy, they are very much rigid neck sometimes. The dynamization is very difficult. Our patient is afraid about any kind of movement. In this particular situation, as a surgeon, for the flexion, extension, do you face any adverse effect in your series?
Actually, in all our dynamic MRIs, or if at all we are doing a dynamic X-rays, we do tend to give them IV analgesics or intramuscular analgesics with muscle relaxants before we do any dynamic X-rays and MRIs. So only this situation arises when you have a overt instability, like in a traumatic situation or in a infective C1, C2 instabilities, where there is a huge amount of tenderness which is there at the same level. Otherwise, most of these spondylotic myelopathy patients, they have pain during extension, not during flexion or a neutral. So in extension, you can just keep them for a, it basically, the way you position them, they will not be able to lift their head from that position. But then it's always better to ask your patients whether you will be able to be in extended position for at least 10 minutes. If not, better to give them intramuscular or IV analgesics with muscle relaxants, then only better to do a flexion extension MRI.
Thank you very much, Guru. There is a memento for you. Please. So next speaker, Professor Shalom. So, Professor Shalom, will you please continue your talk? You will talk on single multi-level cervical spondylotic myelopathy. How far anatomy anterior only surgery can be contributed? So, I want to draw attention of the participant that says there is another chairperson here, Dr. Ram Chadda. He is from India. He is the president of Indian Orthopedic Association, and he is a spine surgeon.
Okay, good morning. So, Honorable Chairperson and distinguished gathering, today is a lot of discussion and talk on CSM because it is very bread and butter of a spine and orthopedic surgeon. So, my talk is on the single or multi-level cervical spondylotic myelopathy, how far the anterior only surgery can contribute. I am Professor Shah Alam, the Chief Consultant of Bangladesh Spine and Orthopedic Hospital. And as all of you know, the cervical spondylotic myelopathy is basically produced or developed due to compression, and mainly the degenerative changes, and is one of the most common spinal disorder in adult. And the etiology is mostly the cervical canal stenosis and also degenerative disc disease and OPLL, and sometimes the hypertrophied ligamentum flavum. And this is the picture you can assess the radiologically and CT scan and MRI, when the cord is compressed and produces the symptoms. So thus clinically, mostly it is a diagnosis when patient cannot stand, walk, and clumsiness, along with the neck pain, numbness and arm, and sometimes also bile bladder involvement, and maybe having with the symptoms of the all limbs. And it is usually initially maybe the neck pain, then it's a bilateral involvement. Diagnosis is mostly done in the clinical history and the thorough examination and also the investigations. The investigations is the plain X-ray, and sometimes we do the dynamic X-ray as well, and also oblique view X-ray. Other than this, the MRI is the gold standard, but sometimes also we do the dynamic MRI when there is no correlation with the clinical findings and the radiological imaging. And also we do sometimes the CT scan as well. So the indication of surgery when there is a progressive myelopathy and it is scored by a modified Japanese Orthopedic Association, the severe myelopathy, or it is a less than 12, then we go for surgery. Sometimes also we do the relative indications when there is the mild or moderate varieties of, the scoring, then also we plan for surgical investigation, intervention. As because you know when there is a myelopathic sense, it is a progressive, and it is usually doesn't reversible. That's why the indication of surgery is very clean cut. The aim of surgery is mostly the decompression of the neural tissue, that the spinal cord, and the stabilization and fusion. So the anterior surgery might talk in favor of the anterior surgery, and anteriorly we do the ACDF and most popular and ACCF. So this is the picture of the ACDF and ACCM, and also the posterior surgery one picture. But our target is to do the anterior surgery. So when we'll go for the anterior surgery, already it is mentioned the K line is the most important thing is that when the K is negative, that is a minus, and the patient having with the kyphotic deformity, we plan for the anterior surgery. And when the K is the positive, then we go for the posterior surgery, and it is mostly assessed in the OPLL cases. So how far the anterior surgery, how far the anterior surgery can contribute. So if you see this is the one level, the CSM, definitely we go for the surgery in anteriorly, and the two levels also can be done, the anterior approach anterior surgery is possible, and also up to 3 levels it is possible to do the surgery anteriorly very successfully. So the indication of the anterior surgery when there is the post-level disease and the pre-existing fixed, the kyphotic deformity along with instability, and also 3 or less than 3, the segmental compression, your plan should be the anterior surgery is preferable. So the option is a ACCM and ACDM. ACDM, what we do, we remove all the stupid, the devitalized, the abnormal tissues, mostly the disc, osteophytes, everything should be removed to see the cord very free. And the restoration of the lordosis and also indirect decompression by doing the distraction and stabilized by instrumentation. So up to 3 level, we can achieve the good correction and good fusion and stabilization. But there's some limitation, that is the less visualization and the chance to damage the neural tissue, but it is not suitable in the congenital spinal canal stenosis. So in the one case, if you see that is the one level, the CSM at the level of cervical 4 and 5 and not improved by conservative treatment, and there is a progressive neurological deficit started, then we plan for surgery. This is the ACDF done and the stabilization done by the standalone cases with bone graft. So it's a one level surgery. This is also the example of the pre-operative and post-operative X-ray. This is another one level, and modified Zoe score was 12, so we planned for anterior surgery. You see that after surgery, patient can walk, but initially he was had a difficulty to walk and stand. The another patient having the 6-7 level, 56 years old man, the Zoe score 12, and we performed the anterior surgery. This is the 2-level CSM at the level of cervical 5, 6, and 6, 7, about 35 years old man, very young, but having with the progressive myelopathy, and we did the surgery anteriorly, and subsequently we see the patient having with the good, the movement, no neck pain, and the patient having the good neurology. And this is another patient with the 2-level ACDF was done, the 2-level, the CSM at the 5, 6, and 6, 7. And subsequently you see the patient can walk without any support, and his neurology has improved. This is another patient, the 3-level, the CSM, cervical 2, 3, 3, 4, and 4, 5. We performed the single setting anterior approach, and it was stabilized by standalone cases of bone graft. And cervical corpectomy, the 2 vertebrae, 1 vertebrae, and 2 level above and below the disc was removed. The problem is that to some extent it becomes the instability can develop, but it's a good case of when there's a huge compression, we do the ACCF. This is one case, 65 years old man having with the CSM at the level of cervical 3, 4, and 4, 5, and the jaw score was 10, so the almost the severe variety, and we did the ACCF and stabilized by cases with bone graft and cervical plate and screws. And you see this patient initially just could move his upper limb and the lower limb as well, but couldn't stand and walk. And immediately after surgery with support, patient regained his neurology. And if you see the few days, the 5th post-operative day and 1 month after surgery, patient having with the good, the work without any support. So this is the benefit of SACM. Sometimes we did the second surgery. This patient had the 2-level, the CSM, and I did a person 15 years back the SACM, and it's a good fusion and good, the solid bone formation was done, and I removed the plate. 15 years after, this patient came to me with the 2-level CSM. You see cervical 3, 4, and 6, 7. So now we're going to do approach. We're going to approach the 4-level surgery, and I did the the ACDF, the above 3, 4, and 6, 7, and subsequently we see the patient the good the neurological function. So it is possible even the more than 3 levels, although it is mentioned that 3 levels, but we have performed the 4 levels. So there are some complications. The most common complications of anterior surgery is the dysphagia and also the adjacent segment, the disease. But also sometimes it happens that the non-union. So the take-home message, the anterior surgery is a very simple, less bleeding, and less painful than the posterior surgery. And if you see the pain relief in the neck region and the arm region about the 90 to 100% there is the no pain, and in the neck pain about the 73 to 83% there is the no I mean the improvement of neck pain, and the success rate about is 85 to 95 in the anterior surgery. Thank you, but the good team and with the joint venture, if we do the surgery, good planning, we can achieve the good the result. Thank you very much for your kind attention.
Thank you very much, Professor Shalom. The floor is open for the question or comments. Is there any question, please? First speaker, Kamrul is here.
Oh, yes. Yes. I have got one question. Extension, hyperextension or extension? You mentioned extension. Thank you very much. It is a very interesting one. I think whether it is for the surgeon or for the radiologist, both should know that how much it is required. So far the extension, is it hyperextension or extension? Number one. Number two, how much extension, is there any degree that extension will give you the best picture? And then the next question is that you mentioned about the 1.5 TSL, that if it is more than that, if it is a 3, then what it would be?
Your first question, whether it is extension or hyperextension, it is not both. Basically, we need to ask the patient to extend to that level where he is able to extend. So it's at the extreme range of movements actually. So flexion is completely till the range he is able to do, and extension is to that degree till the range where the patient is able to do. Sometimes in a severely spondylolytic spine, patients are not able to extend too much. Their extension is automatically restricted. So we are not going to force him, we are not going to manually force the extension. So it is the range of motion which is patient is able to do by himself, because this is the range which he is going to have in his day routine activities. So this is the range where when he is going to sleep, if he is not using a pillow, this is the range where his spine or the cervical spine is going to extend. So I wouldn't say it's just an extension. I would say it is an hyperextension till where the patient is able to do his extensive movements. And there is no certain degree of extension where we can reveal the extra compression levels in extension. It can happen at 15 degrees in some patients. It can happen at 40 degrees in some patients. It can happen at 30 degrees in some patients. So there won't be a particular degree, because it all depends on your ligamentum buckling. How much is the ligamentum buckling is happening, and how good is your disc heights. The more the disc heights, the more the ligamentum buckling happening. So if you have a good disc height with the ligamentum hypertrophy, so you can have a ligamentum buckling and compression in a 15 degrees. If you have already decreased disc height and it's almost fusing that level, so then the ligamentum buckling is lesser. So then in that cases, it is the lamina which pinches, not the ligamentum flavum which pinches.
Thank you. And what about that
1.5 and 3 Tesla? Because if you do a lesser than 1.5 Tesla, 1 Tesla or a 0.5 Tesla, 0.25 Tesla, you won't be able to judge basically the hyperintensity zones that clearly. But then with 1.5 Tesla and above, it really becomes easier to do this. And for all practical purposes, 1.5 Tesla MRI for spine is better as compared to a 3 Tesla MRI, because 3 Tesla MRI is mainly for musculoskeletal and joints rather than it's for the spine.
Thank you. Thank you very much.
One thing I would like to mention, probably sir concerned about the hyperextension.
No. Not on that, but
No, sir.
I'm curious to know that
We are very much alert whenever patient is undergoing a surgery. We call the anesthetist, please don't go for hyperextension, because the patient is unconscious. In this period, you will alert the anesthetist, please don't go for hyperextension.
Okay, thank you very much. But I want to request one of the chairperson, Dr. Ram Chadda, sir. You overall comment on this session, please.
Thank you very much, sir. It's been an excellent session. One thing which we need to understand in cervical spinal myelopathy is that there is a tendency, at least in my country, and I'm sure it's so in Bangladesh as well, that most patients deny or defer consenting for surgery because it's a very, very high risk surgery. However, they need to be properly counseled, and an important part of counseling in myelopathy of the cervical spine is that they have to be given the choice between what will happen without surgery versus the worst case scenario that can happen with surgery. Because if people are going from a walker to a non-walker and they are losing their balance and voluntary control over bladder and bowel, quality of life is significantly getting affected. And hence, they should be told that the worst case scenario with non-operative is at times far worse than the worst case scenario of operative. So that's one point. Second point, which is very important, which we are using, and actually, at least in Mumbai, we are enforcing it. We always like to do a good intraoperative spinal cord monitoring for all patients with myelopathy. And we tend to use, as far as possible, ultrasonic bursts for this. These are two things that we are finding significant shift in the post-operative convalescence, where if you have intraoperative spinal cord monitoring, you can actually prevent something which is the worst case scenario. That means patient is alive but can't move. That's worse than death for me. And second is using the intraoperative bursts and doing the surgery slowly under monitoring. So please do try and follow this. It may take longer, it may be a little expensive, but in the long run, these people also deserve to live with good quality life. So thank you very much for a patient hearing.
There is another presenter, but he is late to come here. He went to for another room for presentation. So we have to choose over for the next presentations. He will come. We will allow him to present. So I will. It's my pleasure to request Dr. Munjirul Haq Akunda Chaudhary. He is the chairperson, and Dr. Monirujaman Shahin. Are you here? Dr. Monirujaman Shahin. So, and Dr. Fazul Haq, please continue the session.
Thank you, everybody. In this session, probably one or two papers already presented by the living surgeons. No, tinte. Acha kunta? Kunta. May I request Dr. Rajol Karim to present this paper. The subject is surgical correction of adolescents idiopathic scoliosis and his experiences. Professor Rajol Karim, please.
One.
Good morning. Honorable Chairperson, dear audience, my teacher, I am Dr. Rajaul Karim. going to talk on birth of a child is a divine and bears lot of happiness and enjoy for family. But sometimes this enjoyment and happiness become unhappy and sorrow and bear a frustration for the family. Because when the child grown up with deformity any part of the body like spine, that is scoliosis. So my talk on surgical correction of adolescent idiopathic scoliosis, my personal experience. I am working in NITOR as a professor of orthopedic surgery and newly an spine unit. So scoliosis surgery is a big surgery, making a big scar in the back of the body or lateral side of the body. But patient code is the scar, surgical scar is so less than the mental or emotional scar which is produced by scoliosis. So it is not only physical but also social and emotional burden to a patient, especially young adult. Like other disease, the scoliosis also has a long history. Spine have been mentioned in Corpus Hippocraticum. In 1971, Nicholas Henry devised the crooked tree symbols of crooked spine in the book of orthopedic medicine. So scoliosis term derived from the crooked tree. A lateral curvature is more than 8 or 10 degree. We call it scoliosis. This definition is derived by Scoliosis Research Society. It is three-dimensional deformity, both sagittal, axial and coronal plane. So etiology is unknown, but it is a multifactorial disease. How curve progression? Curve progression depend on if patient is suffering from double curve. This double curve is more progress than the single curve. Thoracic curve is more progress than the lumbar curve. More severe curve become more severe. And immature or skeletal immaturity curve progress more than the skeletal maturity curve. We assess the skeletal age of the patient by riser sign. How can we evaluate the patient? We evaluate the patient by taking detailed history, physical and neurological examination. We can also identify the spinal balance, both coronal and sagittal balance. We also determine how much the curve is severe or mild or moderate. We detect by measuring the curve angle. So in this AIS treatment, we need some strategic vertebra like stable vertebra, neutral vertebra, end vertebra, or apical vertebra. So measurement of the sagittal balance we can do from the C7 vertebra or from the base of the skull. How can we classify the AIS? AIS can classify by Ponseti and Friedman classification King classification and gold standard Lenki classification. The worldwide popular classification, the gold standard classification of AIS. It is depend on identification of the primary curve, assignment of the lumbar modifier, and assignment of the thoracic sagittal modifier. So designed to guide surgical treatment decision making. There is an article between the King and Lenki classification. Treatment. We can treat the patient by observation. If the patient present with mild curve, we observe the patient. How can we observe the patient? এটা স্ক্রিন চলে না এটা আমার প্রবলেম না প্রবলেম তো এখানে We also, before surgery, we also treat the patient by using brace. These are the sorts of brace, BOSCON brace. We use, if the patient suffering from the lower thoracic curve, we use the underarm brace. This is BOSCON brace. If patient suffering from thoracolumbar curve, then we use the Miami. And cervicothoracic or upper thoracic curve, we use the Milwaukee brace. The operative treatment, when the patient, when we go for decide the surgical treatment, if patient present with more than 40-degree curve, that is the severe curve, and increasing curve with growing child, thoracic lordosis, patient present with scoliosis, thoracic lordosis, and significant cosmetic deformity. These are the indication for the surgical treatment of AIS. In my series, there are 30 patients from 2016 to 2023. Surgery done in single stage in posterior surgery, curve angle measurement, VAS and ODI. These are the outcome analysis. Sampling technique, the more than 40-degree curve, and complete at least 6-month follow-up were included. These are some cases. I did the surgery in posterior, the preoperative X-ray, post-op X-ray. The 13 years girls, Lenki type 1, the pre-op X-ray and post-op X-ray. Another patient, 15 years girls, Lenki 2, the pre-op X-ray, the pre-op and post-op X-ray. Another patient, 14-year girl, Lenki 3, the pre-op X-ray, the paraoperative X-ray, a paraoperative photograph, and post-op X-ray. Another, the final outcome. Another 17 years girl, this is the Lenki type 3, AIS. We did posterior surgery. Another patient, this is the final follow-up. So, mean curve angle was 76.8 plus minus 6, which was improved to 16 plus minus 3 degree postoperatively. 3 patients developed transient neurodeficit, which improved with time of average 3 months. 1 patient had superficial wound infection. VAS and ODI improved significantly. Conclusion is, we are always stage of fear because we have no neuromonitor. I have no pneumonia in our hospital, also my private hospital also. For this why scoliosis surgery is always associated with the development neurodeficit. So I always fear during the surgery. So scoliosis correction is difficult as well as the challenging surgery. Surgeon experience along with proper preoperative evaluation and preoperative planning is the key to success. So thank you for patient hearing.
Thank you, Professor Raja, for nice presentation. Next presenter is Professor Arnold Chaudhary. Arnold Islam Chaudhary. Yes. You are invited to present your 2 papers, probably. Consecutive 2 papers. One. His paper is cervical OPLL, anxiety of a spine surgeon, how to manage safely. Professor Anwar Islam Chud. He is the chairman of Department of Orthopedics, Bangabandhu Medical University.
Thank you, dear organizer, giving me the opportunity to present this. Ossification of the posterior longitudinal ligament in the cervical region is definitely a problem, and definitely a problem for the not only for the surgeon, for the patients as well. And etiology, it is multifactorial condition. It may mimics with the metabolic disorders such as obesity, diabetes mellitus, acromegaly and hyperparathyroidism are often linked with the OPLL, but it may mimics with the DISH, diffuse idiopathic skeletal hyperostosis. It is the misnomer. Incidence is common in Japan and East Asian region. Once it is called the Japanese disease, and most frequent age is 40 to 60 years of male, and male are more sufferer, most often affecting the C5 region. This is the classification, you know, continuous variant, segmental, mixed and circumscribed. How to manage? It's really a problem for the spine surgeons. Preoperative factors adversely affecting the clinical results include the increased age at operation and increased severity of the pre-existing myelopathy and a history of trauma. Presentation, you know, all of you know that the axial neck pain, there may be radiation. The patient may present also with the myelopathic sign and myelopathic hand sign as well. Investigation, only plain X-ray, CT scan. CT scan may show the double layer sign on axial bone window. This is the diagnostic for the proper diagnostic features for the OPLL of the cervical region. An MRI to see the neural condition. Is there any role of conservative management? This is the question. Non-operative management can be undertaken for the asymptomatic patients without severe cord compression or myelomalacia on CT and MRI. Conservative strategies should include the physical therapy, cervical orthosis, non-steroidal anti-inflammatory drugs, and activity modification with avoidance of the high-risk activities. Patient conservatively managed for OPLL should be followed up closely and educated about an increased risk of spinal cord injury secondary to the relative minor surgical trauma. This is on paper which shows that an OPLL is 4.8 folds higher risk for cervical spinal cord injury. Surgical management of OPLL, usually indication is the neurologic syndromes which is worsening day by day, and if there is myelopathic sign appears, a variety of the surgical approach can be offered for the patient. Anterior approach, posterior approach, combined anterior-posterior approach. Each approach comes with unique risk with benefits. This is the anterior approach. There are many advantages and also have disadvantages, you know. This is another paper which shows that dural tear are encountered in up to 20% of the patient due to the attenuation and adherence of the ventral dura to the OPLL. Nerve root pulses are reported from 4 to 17% of the anterior approach and most commonly in the C5 distribution of the nerve. Posterior approach, posterior based approaches are useful for longer segment. If it is involved 3 or more level of the OPLL, the posterior approach is better than the anterior approach. The kyphosis line or K line is a straight line connecting mid-canal C2 to C7 used as a radiographic predictor of successful posterior base decompression. Laminectomy or laminoplasty may be preferably in an extensive OPLL that is continuous or mixed over several levels. This is another paper which shows the K line of the lateral view X-rays and are associated with the improved outcome after posterior base decompression. Laminectomy is one option. So, this paper reported a mean improvement in JOS score of 62% at 5 years of laminectomy and fusion with greater improvement in JOS score associated with greater postoperative lordosis. A decompressive laminectomy as well as the lateral mass fusion and fixation, it is the standard treatment for the OPLL of a long segment in the cervical region. Laminoplasty is another option. It has some advantage and disadvantage, but it is better in a single level or focal OPLL or a segmental OPLL, but in a long continuous OPLL, laminectomy, decompressive laminectomy and lateral mass fusion and fixation is the best of our treatment for the patient. While laminoplasty allows for continuous motion of the cervical spine, OPLL has been documented in progressing up to the 70% of the patient. Even within the laminoplasty, the OPLL may be progressed. Our experience of 2 cases I want to show, you just see, this is the X-ray of that patient and this is the CT. You just see the OPLL level at the C3, C4, 5, 6, even 7 involved. This is the axial CT, how much the cord compression by the OPLL, you just see. This is the MRI of that patient which shows the multi-level compression over the spinal cord and myelopathic presentation, clinical presentation of that patient. What did we do to manage these complex cases? Posterior decompression by laminectomy of C3 to C7 vertebrae and stabilized by lateral mass fixation from the C3 to C6 and by pedicle screw at C7 vertebral level. You just see this case. Take home message, OPLL is a challenging cervical pathology that can potentially result in spinal cord compression from the ossified posterior longitudinal ligament masses. While asymptomatic patients may be managed conservatively, patients with radiographic fissure, positive myelopathic sign, clinical presentation with neck pain, axial pain and the radiation, definitely do surgical intervention. In a focal OPLL or segmental OPLL, you can do the corpectomy and fusion and fixation, and in a segmental OPLL you can do the laminoplasty, and in a continuous OPLL you can do the decompressive laminectomy and lateral mass fusion and fixation. Surgeons should prefer for dural ossification and adherence if removal of OPLL is performed. Thank you everybody for patient sharing. My second one.
Thank you.
Can I continue, sir? I saved many times, so I can, can I continue? Sir.
One question from Professor Hawk.
The question is that, do you know the OPLL surgery is really very difficult for the surgeon, especially for the dural tear, as you mentioned also very clearly. So what you did in your cases when there is a dural tear?
Sir, in case of OPLL, if it is focal or segmental, when we go for the corpectomy, in that situation there is a risk of the dural tear. But if you do the posterior surgery, you can safely did it and do it.
Sorry, in posterior cases, what you do, Anwar?
If dural tear,
yeah,
definitely it can be repaired because there is a wide laminectomy or decompressive laminectomy.
When there is a, in what I faced, there is a progressive ligamentum flavum ossification. We did this surgery. There is a dural tear. Because dural tear is usually happening with the pons out. So it's very difficult to repair unless otherwise you put some graft.
Definitely, sir. If OPLL has two layers, superficial and deep layer. Usually, deep layer is adherent with the dura. So, in that situation, if you go for the anterior surgery, it is difficult to be repair and reconstruct. You can only put the fat faces and other things to be, or surgicel or surgical can be putting over there. But in the, from the posterior side, if you manage this dural tear, you can manage by easily by reconstruction from the deep fascia taken from the cervical lesion, and you can reconstruct this.
Thank you, Professor
I
Alum.
just mentioned my experience. Once I have faced this problem, there is a huge dural tear. It's not at all possible to repair or do anything. What I did finally, I just put the surgicel and close it, and I was so much worried. But after 2 days, I have find this everything is sealed. No, there is no CS application.
Thank you,
That's
sir.
it.
Thank
Which
you,
I have
Professor
already
Alum.
mentioned, sir.
Next speaker, Professor Sahalam. May I request Professor Sahalam to present this paper, very interesting paper. To all spinal injuries need decompression. Very interesting issue. Session A1. Session A1.
ওরা কোথায় রাখছে এই অডিও ভিজুয়ালের লোক
This is next to spinal symposium session. Session A1.
না সিম্পোজিয়ামটা তো হয়ে গেছে সিম্পোজিয়াম না এর পরের সেশন যেটা
Next to symposium.
হ্যাঁ next to symposium.
আরে না কিসের সার্ভার আমি না না
A1. A1.
সিম্পোজিয়ামের পরেরটা এই যে সেশন সেশনে
না 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 দুইটাই দেওয়া হয়েছে কোথায় রাখছে
Sorry. Sorry for the inconveniences in presenting the last paper of this A1 session. I will be allowed to present this interesting paper from Professor Salam later on in suitable time. No, there's not. No. Now the time for questions. Professor Rajal Karim and Professor Arnold Islam, please. Professor Anwar, please. Professor Shah Alam, please.
Thank you.
পরে সেশন ডিক্লেয়ার করো।
প্রফেসর আনোয়ার ইসলাম
প্রেজেন্টেশন আছে তো স্যার, এটা শেষ করে নেই স্যার।
কোনটা? নো নো
স্যার, এটা তো করতে আমাকে স্যার বলুন।
No,
Professor Anwar Islam, please.
The next session,
Moment two.
next section, Chairperson Dr. Jiaul Haq, Dr. Arvind Puri, Dr. Fakhrul Amin Khan, and Dr. M. Saidul Islam. Yes. না পাই নাই তো।
And Professor Rajal Karim. Thank you.
আমি তো যাবো, আমি তো চেয়ারপারসন। আসেন, দাও দাও, আসেন। এই তোমাদের এই অবস্থা, এই স্ক্রিনে দাও না। কি লোক রে এগুলা, তুমি দেখো। আসছে। So good afternoon. So I am talking on do all spinal injuries need decompression, because it is a very important, especially in the spinal trauma. When we were taught and we had a training, every time we came to know that the decompression and stabilization. So without any decompression, stabilization or fusion, no recovery can be achieved. If you see these, the CT scan, when the burst fracture compressing the cord and the canal and foramen, everybody will ensure and will like to decompress. So I'll coming back what we did or what is the principle now. This patient didn't have the total neurological loss, only the ACR-D. So this is, you can see the all canal, the foramen is the compromise. So basically, what are the principles for decision making in burst fracture in the thoracic, thoracolumbar and lumbar region? First is the neural decompression, stabilization and fusion that we are learning and listening. So how to do this decompression? There are two ways to decompress. One is the indirect decompression by doing ligamentectomy, and other one is the direct decompression by doing laminectomy, or also we do the transpedicular decancellation or decompression. So these are the ways to do, the direct decompression. So how the other people or the world is doing, if you see the the article, is there any necessity to do the direct decompression for thoracolumbar junctional fracture when there is a neurology is compromised? It is seen that they found that no basic differences in outcome when the direct decompression versus indirect decompression by ligamentectomy. So there are other articles that the clinical results of posterior stabilization without decompression for thoracolumbar burst fracture is decompression is really necessary, and it is seen that no decompression, direct or indirect, even in the presence of the reverse cortical sign. So when there is neurological deficit, is there any direct association between the severity of the initial canal damage and neurological injury, still it is unknown. That's why there are other paper, they are talking or they are claiming that there's a correlation between the neurological deficit and spinal canal compromise. They analyzed 198 patients. Yes, they found the positive correlation between the spinal canal compromise and the severity of the incomplete spinal cord injury. But they are confused because they are unable to explain when there is a Frankel E and Frankel A patient having the same, the canal is compromised by bony fragments. That's why question again arises that neurological injury in thoracic lumbar fracture, is there no significant correlation between the bony or canal disruption and the degree of neurological deficit, but the significant correlation between the energy of the injury and the subsequent neurological status. If you see that this, the axial section whole, the canal is compromised, but there is a way to the progressive remodeling occurs in the first 12 months after injury. And even the retropulse bone shrank to about 1/3 of the initial size within the 12 months. That's why people think that there is some auto or spontaneous regression of the canal recanalization. You see that immediately after injury, 2 weeks after injury, and 2 months after injury, there is some, the remodeling. That's why the bony fragments in the canal usually do not represent a continuing compressing force to produce the neurological deficit. So there is the neurological deficit, the recovery starts even before surgery. So surgical canal clearance doesn't affect the extent of the neurological deficit. So no correlation between the canal compromise and neurological deficit at the time of injury. So neurological recovery and spinal canal compromise at the time of injury. So the initial impact, the damage that happened, that is permanent. And subsequently it starts to regain, but even the bony fragment can compromise the cord or roots, usually doesn't produce the further progression of the neurological deficit. So in our perspective, or all over the world, they are in a consensus what we do now. So when we do the direct decompression, we'll do when there is a reverse cortical sign and laminar split sign and neurology less than 3 or less than 3, mind it. So now it goes when the Asia A and B, mostly it needs to require the, the decompression. Otherwise, it doesn't help to decompress. But when the spine is unstable, definitely it requires to stabilize, it requires to fuse the spine. So about the reverse cortical sign, it means the fragments and they flipped about 180 degree and the cancellous part becomes in the canal. And in that case, it requires the surgical decompression. But ligament textus is contraindicated in this case. So there are some pseudo cortical sign. It means that not 180 degree but 90 degree. The flipped the posterior fragment. In that case, the rotation when 90 degree. Yes, in that case the ligament textus is helpful. For an example, come back to the first case that I have shown. That is without any decompression, just stabilization and holding the intermediate vertebra. That means the fracture vertebra incorporated, and the good result is the came. Another patient is having with the Asia C L1 burst fracture, and we did only the stabilization, no decompression. And if you see the L2 burst fracture, if patient had Asia D and subsequently the canal is the recanalized and the good correction, there is only the few degrees of the the kyphotic angle. So and finally the canal was found. There is no compression by the bony fragment. So another patient, the Asia D L1, we did only the stabilization, no decompression, and subsequently you see this patient is a good, the neurology can work without any support. Another patient is the L1, L2. Basically it is not D, it was the Asia C, and we decompress posteriorly, and you see this is done by MIS technique, and subsequently patient the regain and the retropulse fragment that is the recanalization by automatically, and only after surgery we see the only 23 the kyphotic angle. Another patient it was done by MIS technique and L1 burst fracture Asia D, we did only the stabilization, no decompression. If you say after injury, if you see the first axial section by CT scan, and after 6 months it has to totally recanalize. There is no fragment, so it is automatically, the spontaneous resolution of the bone fragments happens, so no need to do all the time go for the decompression. In our series, the 33 patient we analyzed, and the criteria was the thoracolumbar fracture, and the 25 patients regained neurology at the time of follow-up, and the mean operative kyphotic deformity initially is 22 plus minus 4, and which became the 10, and ODI score, the improved the preoperatively, it was 67, and after surgery it became the final, the 25. So the take-home message is that when there is no deficit, no decompression. So ligamentexis can be done in most cases and is an effective as direct decompression. So careful patient selection might avoid the direct decompression as well as save the operating time. Thank you for your kind attention.
Thank you, sir, for your nice presentation. Sir, have any questions, sir? Only.
Does not as, because, and I have shown, because
Monzo sir,
initially when you have seen that there's a canal is compromised, but the neurology was say shared D. So, but unstable spine, we stabilized, and the neurology regained. So no need to go do the decompression. That is our principle.
thank you, sir. No more question. Sir. So our next session, session A2. This is the Professor Dr. M.D. Muazzam Hussain Memorial Session, Trauma Session 1. This session will chaired by Professor Dr. Ziaul Haq, Professor Arvind Puri from Australia, Professor Dr. Fakhrul Amin Khan, Professor Dr. M.D. Saidul Islam. I am requesting all the chairperson, please conduct the session.
Thank you very much. We are in a hurry. Probably there is no other chairperson, so I have to sit in 4 chairs. Sorry. Sorry, sir. Dr. Arvind Puri is here. Okay. So I will sit in 3 chairs. So first, I am starting this session with Dr. A.H.M. Abdur Rauf of Bangladesh. The subject is dynamic hip screw versus proximal femoral nail for intertrochanteric fractures. I don't think so, because when also we have to put another one in this chair. They have the looking for. Should keep going, and just comment on.
Very good afternoon, Chairperson, my senior teachers, learned audience. So my topics, the intertrochanteric fracture management. It's the really a controversy.
Sorry, I just want to interrupt, Dr. Rauf. Yes. We want to finish it in time. So if the time is up, we'll ring the bell. Okay?
Oh, thank you very much.
Thank you.
Let me start again. Intertrochanteric fracture management, PFN or DHS. The learning outcome, implant size, and the procedure step by steps, and how the complication can be avoided. The mostly extracapsular and the proximal femoral fractures, about 65% of the total cases. Age variations 65 to 80 plus, male female 2.8 to 1. And the very low energy trauma are the most the cause, 50% women, 5% men. Osteoporotics are the most common issues. The surgeon's classification, the stable and the unstable types. The stable types is very easy to treat by any means, and the unstable type is very difficult to treat. The unstable fractures, the posteromedial combinations, reverse oblique, IT fracture with subtrochanteric extensions, lateral wall blowout, and the severe osteoporosis, most the unstable fractures. Treatment goal: stable fixation, early mobilization, full weight bearing, and early ambulation. Treatment options of the intertrochanter fractures: DSS, DCS, proximal femoral locking plate, and PFN, PFN-A and 2. Available implants: the DSS and the trochanteric plate, PFN, and the arthroplasty also. The intertrochanter fracture fixed by DSS, restoration of anatomy and the good function is our goal, but happy outcome does not occur always. The incidence of failure, unstable intertrochanter fracture, 5 to 13%, which is very high. Common modes of failure: cutout, excessive collapse leading to medializations of the distal part, and the shortening, separation of the plate for the femoral shaft. And this is the medialization and the broken implant and the screw cutout. Our experience: the fractures fixed with the DSS, after few days it becoming the failure, and the patient can walk but with pain. And this is the failure, how the failure is occurring, and gradually the medialization and this medialization is compromised, is improvement by the trochanteric stabilization plate, which cannot fulfill our desire. And then, is it the DSS is the still choice of implants for the intertrochanteric fracture, especially for the unstable type? No. My talk will go in favor of the PFN. Proximal femoral net introduced by AO in 2003. And the trochanteric fracture is fixed by PFN, PFN-A, and PFN-2. Advantage of the PFN: biological, less invasive, short load tearing, less time consuming, less blood loss, less reduced liver arm, less telescopic. This is seen the reduced liver arm by the DSS and the PFN also. Less telescopic. In case of PFN, it is less telescopic, and prevents medialization, as because nail acts as a buttress of the medial wall. As this is the improvised, we have overcome our problem by doing the PFN. No, it does not happen always. Between 2003 and 15, various studies regarding failure pattern of PFN have published. What the lessons we have learned? Reduction, reduction, and reduction. For PFN, reduction is a must before the entry of the nail. PFN is a tool for fixation, not for reduction. Entry point decides the surgeons as well as the fractures fate. The entry point is a very important part of the, this is the medial part of the greater trochanter. And the never accept the varus reduction. The Z effect and the reverse Z effect, also the complication of PFN. Methods. We have 170 cases of trochanteric fracture, and out of 170 cases, 91 are the PFN. The results: excellent 20, fair 25, good 15. And this outcome is assessed by Harris hip scoring. Few cases of our hospital, after 1 to 2 months, the patient can be can walk with or without support with PFN. The date of surgery is 16/8. and the follow-up on 24/10. After 2 months, patient is walking with PFN. This patient age is about 100 plus. After before 1 month, at the time of stitch off, he is walking with PFN. It's a very disaster case. How can be treated? Can you think? Only is the answer PFN. PFN, long and short. I would like to request everybody, please give the long PFN for the difficult cases, osteoporosis cases, secondary cases, and where the pathological fracture is there. Tips and better outcome. No lateral wall, no hip screw. Reduction is key. Do not hesitate to open. Even the reduction is not achieved by close method. Always keep a DHS standby. Never use a hammer. Avoid varus reduction. Size of the nail, short nail and long nail, I have discussed. High TAD is bad. TAD should be less than, TAD ruler before 25 ml should not apply for PFNA. It's a very short video of PFN. It takes about 15 to 20 minutes.
The screw size is 80.
In conclusion, PFN can benefit part-to-contact fracture, patient with blood loss, short hospital stay and fewer complications compared to DHS. Above all, optimize the patient, treat the patients for osteoporosis, let the patient give calcium, vitamins and minerals, and this is my dream, my hospital. It is a 50-bedded hospital dedicated for the orthopedics. Before I conclude, I must say, all of you take care of yourself, and before taking care of the patient, thank you very much.
Okay, yeah, I just want to add one question, one opinion, I'd rather say. Actually, there is DHS and PFNA. There is stable trochanteric fracture and unstable trochanteric fracture. No, okay, let me finish. There is no, at this point in the world and also in NITO, there is no controversy. Stable fracture can be treated by DHS, but all unstable fracture should be treated by PFN. Thank you.
Thank you.
Yes, we are requesting to take the memento, Dr. Rove. No, Charadek. Okay. Now I am breaking the this sequelae of the presentation. Now Dr. Saigal from India, he will present one cases which was supposed to be presented later because he is leaving soon and we are late in our session. So Dr. Saigal is presenting his paper. Which one? Yes.
Respected Chair.
And his time is?
Respected
8 minutes, and we will give one bell at 7 minutes.
Respected Chairman and the learned audience, I am here to raise the voice of knee. And the knee says that all the knee joint don't need replacement. And you must prove this because our Indian Orthopedic Association has made a committee, knee preservation committee. I was the one of the member of that. And be sure that all the knee joints, they don't need replacement. So I'm starting with my presentation. This is the high tibial osteotomy. This is my patented plate. And high tibial osteotomy, the indication in my plate, there is no age bar. Usually, the high tibial osteotomy is recommended in below the 60 years of age, flexion deformity 15 degree, and the varus deformity 15 degree. But in my plate, I don't get any age bar. If patient is cardiorespiratory markers are good, and you can see the good cortical thickening in the bone, you can proceed for the high tibial osteotomy. These are the planning, how much is the deformity and where is the deformity and where to correct it. This is the usual X-ray. You have to take a long standing X-ray, AP view, and now the software is available to know the angle of the deformity. These are all the normal mechanical angles you all know. This is very important, the Fujisawa point. The proximal upper tibia, if you divide into the 100%, the 62 to 65% is the Fujisawa point. The mechanical axis should go there when you do the osteotomy. This is this slope, the opening wedge osteotomy. It increases the slope a little bit. Coming to the site of osteotomy, it's by my way, it is a monoplanar high tibial osteotomy and generally performed 3 to 5 centimeter below the joint line. And the osteotomy is done just at the upper level of the tibial tubercle so that it exerts pressure and it starts healing faster. This is the cora, you all know how to know this. The cortex on the concave side of the deformity is distracted to restore the alignment, opening an empty wedge that traverses the diameter of the bone. How to take this long X-ray? This is 51 inches of the cassette, and this is 10 feet long from the distance from the patient. There is a change in the posterior slope, but if you use a locking device, in long-term use, it is not there. This is coming to the specification of this plate. It has got the parallel holes over this point, and you can see there are 3 parallel holes, and the second row of hole is a 45-degree angled hole. And these are all parallel holes, and this is second hole is a these are all parallel holes. This is cancellous holes. This is 45-degree hole, which works as a weight bearing hole, because if you think that this plate is a column and you put weight on it, then you can't put weight on it. You have to have a beam like this. So this 45-degree hole this screw will work as a beam, so you can give proper weight on this. And for the osteotomy, I have a block system, and 4 blocks are available. If you put a smaller block, if you put horizontally, it is 4 mm. If you make it vertical, it becomes 6 mm. So you can have different type of the blocks put on the osteotomy side, so that you can know clinically, radiologically, and with the aligner also that the deformity has been corrected, and attach that block with the plate and do the operation full. Coming to the importance of the holes, this is one hole in the upper, this is the second hole in the middle, and this is the third hole. Keep the plate over the skin before the incision like this, so that you can know the upper limit of the plate, and on the second hole just make it at the 45-degree. This will give you idea where you have to give osteotomy. So after giving the incision, just check it with this, and you have to put K wires. It is 45-degree, not working. Video is not working. Okay. No problem, radio is not working. So you can see that I put this K wire, at the 45-degree towards the tip of the head of the fibula, and then another K wire parallel to it like this. On this bone model you can see. And after this, start doing the osteotomy, and initially start with the motorized instrument. When you reach up to the tibial tubercle, just stop there, and you can finish the osteotomy with the osteotome. one is very important point, that while doing the osteotomy, you should flex the knee joint 50 to 60 degree, put Homen under the surface of the posterior surface of the tibia, so that you are sure that there will be no neurovascular damage to the patient. Like this, you start the doing with the motorized instrument and then complete the osteotomy with the osteotome. I am sorry, video is not running. Open the osteotomy and check with the blocks of the different sides. Check full correction of the deformity clinically, radiologically, and by C-arm, and maintain the gap with the spreader. This way you can put the block. You can see the block at there, and then take out the block and attach with the plate with locking screw at the bend. There are 2 holes depending upon the level of osteotomy. If osteotomy level is short above the near the tibia, then you can put block at the upper hole also. This way you can see that on the bone model also you can see that plate fixation. I have got compared with other plates available in our place. In my case, the inventory is small, fixation is sturdy and strong, and fixation, the plate works. As I told you that this plate works as a column and that screw works as a beam to help in weight bearing. Then accidentally, if there is proximal fragment is short, you can replace it with the block. This is very cost effective and very cheap in comparison to the other plate, and it is a monoplanar osteotomy, so you get a good chunk amount of the bone to fix it. This is the results of the plate. I'm sorry, you can see the patient, this is pre-operative, you can see the deformity, and this is fully corrected deformity after removal of the stitches. You can see the pre-op x-ray and the post-op x-ray. You can see that patient is sitting with full knee bending and cross-sitting. Squatting is possible with this plate. These are other patients. You can see the patients. Deformity is fully corrected. I'm sorry, video is not working. Otherwise, I've got a follow-up of 9 years that patient was done at the age of 70 years, and now it is 79 years and doing perfectly all right. These are the another cases. These are the another cases of the high tibial osteotomy. You can see the deformity in this, the virus deformity, and the deformity is fully corrected post-operatively. These are the other cases. Just I'm finishing, sir. Another cases. Coming to the complication, if the implant is removed early, then the correction will be lost and deformities will be there. Delayed usually is seen in diabetics and smokers.
Thank you very much.
Thank you, sir. These are all presentation. My
Dr. Aurobindo Puri will present Dr. Saigal the crest and the certificate. Our next speaker is Dr. Olup Agarwal. He will present the one his regular case here is type 6 proximal tibial fracture, how to deal with them, and another presentation he will also present after the initial one, right? Okay. You first present your regular one,
yeah.
Then the other one. Okay. This type 6 proximal tibial fracture is one of my most favorite subject. I am want to see eagerly, eager to see that. Wow. Yes, and recently I'm using this Elizabeth, especially when the skin is very bad, young person, blister and other things. Yeah. Maybe, but it works because we cannot fix this plates and in the skin condition. No. I've done in last 3 months this too, like this, and the fresh cases, this articular surface just align, give that. I give this severe traction.
Your signal is not.
It's also my favorite subject. Okay. Pilon fracture. Retrograde neck. When I know that the artery is weak, before that, Pilon fracture, I don't try to fix it now because it's very poor. Yeah. And also, type 3, 4 fracture nectaris, retrograde fusion method. Yes, because otherwise.
So I'm so sorry. Thank you, Bangladesh Orthopedic Association, for giving me this opportunity to interact with you all. My chairpersons are very strict, so I'll just stick to my subject. I'll be speaking on proximal tibia fracture type 6, how to really go about it and what you need to know. I'll go with the case example of a 21-year female, had an active female, had an RTA, injured her right knee, reported on the second day. This is the X-ray. Probably you can make out that there is a fracture of the proximal tibia, but you can't make out what actually it is. So how are you going to approach? So normally how it is recommended that get a CT done. So straightway you have a CT. And with these three, you will be able to assess that which column, which part of the tibia condyle is fractured. This is how you assess your CTs. And with this, you will be able to assess the amount of depression. This is how it is. And what next? So you can debate whether to get a CT done immediately or in the second stage. I normally get a CT done immediately because that gives me two advantages. One, I know exactly what I'm going to deal with and I can plan. And second, very important thing, that I'll be able to tell my patient and their attendant that what are you going to throw and what is going to be planned. So that is the reason I always do a CT. So to plan, you need to know the classification. There are various classifications which are there. Like Schatzker classification, we all know type 1, 2, 3, 4, 5, 6. Then there is 3-column classification, which is a simpler one, where you are able to define which column is there. But there is another classification that was modification of Schatzker classification, wherein virtual equator was formed from the fibular collateral ligament to the superficial medial collateral ligament, whereas the posterior column was divided into a posterolateral and a posteromedial. So you have this classification, and then you further divide into different types, type 1, type 3, type 4, type 6. So what are the basic components? If you don't go through all this classification, every proximal tibia fracture has a column. It could be lateral, medial, posterolateral, posteromedial. So here it has a large medial column, a posterolateral column and an anterolateral column. Then the depression of the fragment, which you need to know where exactly it is lying. And then the soft tissue. So they are basically these three components of all the proximal tibia fractures, and accordingly you plan it. So the planning contains that first you need to span these fractures. Never ever try to attempt to fix these fractures initially when they come. Why? Because initially there is a lot of soft tissue trauma, lot of swelling around, and the vascularity of soft tissue swelling is least at that time. So give a time of 7 to 10 days, which is well established by this graph. By that time, swelling has gone down. Look for the vesicle sign. All those vesicles have come down, swelling has gone down. So that's the time when you do your second surgery or the definitive surgery. And how you plan your definitive fixation? Which incision are you going to give? Anterolateral, anteromedial, lateral, or all of them? You need to elevate the depression. So which window are you going to use for elevation of that depression, and how are you going to fix? Are you going to put all the 3 plates, 2 plates, 1 plate, or 4 plate, and on which column? So this makes your complete planning. What about a posterolateral column? How to fix that? There has been a lot of debates that you need a lateral approach, you need Frost approach, you need osteotomy. Let me tell you that this is the part of posterolateral column which is marked by the green, and this is the part of depression of the fragment of the posterolateral column which you can always approach through the posteromedial approach reaching up to the posterolateral column. Only a certain part of posterolateral column marked here with the red, it is that area which needed a specific posterolateral approach to gain the access to this, and these are very rare. Out of 100, probably 1 or 2 cases only need these kind of approach. So the case example we did in spanning, the benefit is that there is ligamentotexis, lot of fragment comes back to their position. Now there is always a debate which incision first, whether an anterolateral or posteromedial. Always give both the incisions, whether you do posteromedial first or anterolateral. Before doing a reduction, always open on both the sides for type 6 fractures. Why? Again, because there is a debate which column first. So the dictum we all know that the column which has the largest chunk, a largest fragment, fix that so that over that you can build up. Yes, but never attempt a definitive fixation before you have temporarily fixed all the column. So open on both the side, temporarily fixed all the columns by a K-wire, then you're free. Then you start from the posterolateral, posteromedial, and come back to the anterolateral side. That is how you plan. So posterolateral, posteromedial, and anterolateral once you have temporarily fixed. So never ever attempt a definitive fixation without reducing all the fragments and temporarily fixing them with a K-wire. So the case example, we did the same. We opened it from the both side, we reduced, we fixed it with the K-wires temporarily. This is how, and now we are attempting the posterolateral column from the medial side. We tried, as you tied it down, you can see in the picture that posterolateral column has been fixed by an oblique plate like this. And then this is how you put your posterolateral plate. Then you come back to the posteromedial plate, fix it. You see it's well reduced, and now you come back to the anterolateral column, slide your plate and do a fixation and complete your fixation like this. So a word about that, do you always do a posteromedial or posterolateral fixation first? So sometimes this may happen that despite you have temporarily fixed, as soon as you try to fix a posteromedial or posterolateral column, the anterolateral column sinks or the reduction is lost. So in that case scenario, you might have to temporarily put a plate on the posterolateral column and then come back to the posteromedial or the posterolateral. So a word about how to put a plate. So always see that the plate is beyond the apex of the fracture and the first screw is at the apex, so it automatically reduce and buttress the fracture over there. So this is how we complete the fracture. This is 6 months follow-up, this is 1 year follow-up, patient is well, and recently I removed the plate for this lady after 2 years. She is about to get married. This is per-op, this is the post-op after removal of the plate. So I'll just take 2 more minutes if you allow me, or 1 minute, sir. Another case example to illustrate the similar kind of fracture. You see the amount of injury this man had. So again, what you do is you define there is a posterolateral fragment which is rotated inside, gone inside, then you have a posteromedial fragment, then you have a posterolateral fragment like this, and then you have a gap which is all around. So you plan like this, you demarcate all your fragments, and then you start planning. So again, I opened it from both the sides. First, reduced the all the columns, did a temporary fixation like this, and then I'm buttressing my posterolateral column through the posteromedial approach in an oblique fashion, then a posteromedial plate and a anterolateral plate, and I complete my fixation this way. So this is a 1 month follow-up. This is 6 months. This is 2 months follow-up. So the quick tips: that these are high energy injuries. Always exclude the vascular injury. Watch for compartment syndrome. Wait till extensive swelling subsides. Identify each component and do a fragment-specific fixation. Sorry, sir. Thank you.
Thank you. I just want to ask one question.
Please,
Do
sir.
you have experience of management of this type 6 fracture, type 5 fracture with Ilizarov?
Sir, I normally don't do an Ilizarov fixation.
Okay.
My choice for all these fractures is always do a plating.
Yes, I used to do all the plates, but recently, as I become old and become more cautious, started Ilizarov. It gives better result and less soft tissue, very less soft tissue complication.
So there are always many ways to do it. People do JS, people do Ilizarov.
Yes, I know that.
And they are good in their hands who are experienced into it.
Okay.
So
Thank you
definitely
very
they
much.
have good result on their hands.
Okay. No. You can sometimes elevate and fix it with Ilizarov.
Where is my?
Yes.
Not coming.
Yes, window. Yes, submeniscus. Percutaneous and submeniscus approach. Okay. Sir, you can start your next
Sir, ask him to
paper.
give me 12 minutes for this. I have little longer.
You do the spanning aspects, elevate with ligamentoctaxis if required something. You go
So,
there.
Chairman sir, I would be starting my
Yes.
other talk. I think
Thank
that
you,
is
sir.
going to be 12 minutes.
12 minutes, right.
Thank you, sir. So, I'll be speaking another simple kind of fracture that is, we always do it, proximal humerus fracture. But my talk would be more on the video presentation for how to do a myophilos. So, we all know that there are different steps which we need. I'll pick up every step and I'm going to tell you the tips about the every steps. So position, there are a lot of controversies and debate that which position and which chair position you need a special chair, a special table. No, just a simple table, rotate the free end towards the head and keep your patient there and put your C-arm across the shoulder. You have to just tilt the head like this and your C-arm is lying here like you can see this too. And you will be able to see exact lateral view of the humerus. Let me tell you, if you need to rotate your arm, you will always fail your fixation, temporary fixation. So for proximal humerus, you need to stabilize your arm. What you need to rotate is always and always only C-arm, and you should be able to rotate it freely all around. With this position, you can see lateral, you can see AP, you can see oblique. And I have never regretted in doing this in this kind of position. So there are various approach. MIPO is anterolateral. This is how you put. You take a mark of the acromion, so the inferior apex of the acromion, and then 5 centimeter. That's the area where you put your proximal incision. How you put that? This is the this is the proximal incision, and I always put a stitch over that 5 centimeter mark so that I don't go away while I'm busy in reducing and doing so many manipulations. So opening is simple. You reach the fascia, and then you will have to identify, dissect the that raphe, that is avascular raphe. Once you dissect that, where you will reach is the subscapularis bursa like this. You cut. Before doing that, you can always palpate the axillary nerve. So you will never ever err. Just put your finger inside and distally you will be able to palpate the axillary nerve, and you will be sure that you are not going to harm the axillary nerve while you are doing on a MIPO. So after that, make a cut over the capsule like this, and there you are inside the fracture site. You will be able to appreciate here once you cut it. And this you can very well appreciate the fracture site. You have reached the fracture site. So the next step would be to reduce the fracture. So what is the proper reduction? So proper reduction, what you want to achieve is to achieve a proper head neck shaft angle. and the medial community and medial continuity, because it has been established by many studies that the delay in rehabilitation because of comorbidities and decreased head neck shaft angle induced by lack of medial support were the primary prognostic factor that led to poor outcome. So mind it, maintaining this angle and medial continuity is the aim of the reduction. How to do that? You have two varieties, varus or valgus. In varus, you can use either K-wire or a suture to hold the fragments, or you can use a joystick or put any periosteum elevator inside and assist it with the arm abduction, and you can reduce. Or the other way, how to reduce it with the plate. So what you do in varus is you put your plate into an angle over the head, align it, pass 1 or 2 K-wire or a single screw, then as soon as you rotate the plate and tighten it over the shaft, it will automatically reduce the head. And that is what AO teaching for the proximal humerus fractures. That is how you can do. The similar way for a valgus fracture, you can use the joystick or K-wire or suture, or you can use the plate to reduce this fracture. Here you just align it on the surface of it. Again, as you tighten up the screw over the shaft, it will automatically reduce the fracture to the shaft of the humerus. This is how you do it. So this was the fracture which I was doing with the MIS. We temporarily reduced it and held it with the K-wire temporarily. Now you can see, and now the next step would be to do a tuberosity fixation. It is very, very important to do a tuberosity fixation. And that is how even with the smaller incision, you will be able to catch up the supraspinatus and the lesser trochanter anteriorly, subscapularis. So always make sure that you have the muscle tendon while you are fixing the tuberosities. Once you have done this, this is a video where you can see that tuberosity fixation is being done easily with the MIPO also. I don't know, I'm always in habit of taking a second bite also for doing a tuberosity fixation. So once you have done the tuberosity fixation like this, the next is probably most of us do that. They pass these thread through the plate and then tie it up. But I normally do it differently. That what I do is I tie all of them together. Now the advantage is that makes whole of the proximal humerus into one fragment, and it makes your life further easier because it's kept in a reduced position, and then pass the plate and tie again through the plate sutures also. So this is how we did that. You can see on the left side there's a fracture which is unreduced. As soon as I tie up all the sutures together, it gets reduced and your life becomes further easier, and it gives added advantage and strength to your fixation. So this is how you do a tuberosity fixation. So I'll show you here how to put and insert the plate. So you have to be careful that you'll have to be on the bone while you are inserting the plate. Use the drill sleeve over the plate to pass your plate inside. So is this the right that what I'm doing? No, I didn't do it right. So I had to remove it because I did not pass my sutures through the end. Once you have fixed in the single screw over the plate, then you will not be able to pass the sutures through the plate. So now I have to remove it, passed my tuberosity fixation sutures through the plate, and then again I'll insert my plate. So always make sure that you have passed your sutures through the plate and then you insert the plate. And the plate would be inserted. Now the next step would be to mark the plate end. Normally once you're doing a Philos, you normally take a 3-hole plate. For doing a MIPO, you need a 5-hole plate because you don't want to get into that 5 centimeter region where your axillary nerve is there. So you have to put a C-arm, mark your end, and you can see that my end is coming beyond that 5 centimeter region of the axillary nerve. So once you have marked, make an incision over there. See that you reach the plate and make temporary fixation with the K-wire and align your plate. Now, how you align the plate both proximally and distally? That it should be 5 to 8 millimeter below the tip of greater tuberosity and slightly lateral to the bicipital groove. How to see the plate position? Do you pass the K-wire, small K-wire through the plate hole? You will always be wrong. You will go proximally. So always use zig. Zig has another hook kind of thing. Through that you pass the K-wire to assess the proximal end of the plate. You will never ever go wrong if you do it this way. After you have seen the proximal end, rotate your C-arm, always align your plate along the shaft. So always look at the shaft also. Once you have seen the shaft, put a temporary K-wire and then you start fixing. This is the K-wire which I am actually putting distally, and then drill hole the screw. So how I do, why am I showing? You will see I am using the small drill bit, not the usual long one. I just do a proximal a centimeter or 2 centimeter of the drilling. I don't always do, because most of these fractures are the osteoporotic fractures. And the other thing which I always do is to cross check the length screw and whether I have crossed the cartilages. I always just put a small K-wire inside and assess that I am not going beyond my cartilage. Always do. That would be easy.